Good morning, good afternoon, and good evening, and welcome to the 2021 Americares Health Equity Summit. I'm Stephanie Kaufman, Deputy Senior Vice President of Strategic Partnerships here at Americares. Thank you for joining us today as we explore a dialogue on health equity. Americares believes health equity is achieved when every person has a fair and just opportunity to live their healthiest life possible, no matter who they are, where they live, or their socioeconomic status. At today's summit, experts from leading organizations will share what's working now and investigate what's needed for a more equitable future. We are going to be doing that through robust panel conversations centering on mental health equity, medicine security, and climate equity and resilience.
My name is Dr. Wando Olaiwola, and I have the distinct pleasure of serving as the Chief Health Equity Officer in an inaugural role at Humana and also as its Senior Vice President. I am thrilled to be able to talk with you about the work that I am doing and some of the framing of health equity I think is important for your conversation for the rest of your meeting today, and also just to share that a lot of my perspective has actually been formed in the free and community clinic space. I started off my career after my fellowship in serving as a primary care physician in community health centers and have a great affinity and love for the work that the community health center system and the free clinics do. So thank you for all of your work and for all of those lives that you are saving and helping. I'll start off, and I'm going to what I want to share with you today is about how we could really center health equity to get towards what we all know as the quadruple aim, which is to improve the way we deliver care to populations, to improve the satisfaction of patients that are getting care in our systems, to be really thoughtful about cost and also the experience of the people that are delivering care. But there's one piece that I think is missing, and that is really what I call the bullseye of that quadruple aim, which is health equity. So as far as disclosures, I'm a physician, so I'm used to giving disclosures before I give a talk. One thing that I want to say is that I don't really have anything that's in conflict with the work of Americares, but I do have important disclosure to share, which is that I am a Black woman and I am married to a Black man, and I have two beautiful Black children. I come from an immigrant family, and all of those things are really important for how my perspective has been shaped. And so I've certainly have this experience of my learned work, which has been informed by my community health practice experience, my leadership in many different parts of healthcare, my formal training in health disparities and minority health. But I also have this important lived experience where I have to think every day about the life and the health of my family, the isms and the schisms that will affect the potential of my kids and my husband and myself. And those are things that are really true and real for my day to day. So earlier in my career, I had the wonderful opportunity as a family doctor to deliver a lot of babies. And I absolutely loved delivering babies. I love the opportunity to bring life into the world and to, work with mothers who were expectant and laboring and the families that were supporting them. And one thing I used to do when I was in those settings, helping a laboring woman and working with the families was stuff that if you've ever kind of been in the labor room, whether it's for yourself or for someone else, could be really annoying. Is I would keep on talking to them and asking them questions like, "So how are you feeling now? How are you feeling now? How are you feeling now?" Between contractions, they would be like, "Leave me alone. Just leave me alone. Go away." But I would do things like trying to distract them from that pain of labor sometimes and say, what are you hoping for this kid? What do you want for this baby? What are your dreams? What are your hopes? What are your ambitions? And I would tell you that regardless of socioeconomic status, regardless of race, ethnicity, language, so many other parts of people's identities, regardless of all of that, every single expectant parent that I had in the labor room would tell me the same basic things that they wanted for this child when it would ultimately be born. They wanted a safe and healthy delivery. They wanted a baby that had 10 fingers and 10 toes and no problems or complications with the delivery. They want them to be even better than I want them to be better than I was. I want them to be achieve more than I ever did. And those are the kind of things that people felt were really important for their babies. So as I got kind of further along in my career and started to think about, how much of that would be true, how many of these babies would achieve their full health potential, as Christine just said, how many of them would be really have the opportunity to live their best life from a health perspective, and where are some of these babies being marked at birth? Because when I think about the future of those babies, I think about the fact that if it was a Native American, American Indian baby from an indigenous population, they would have a significantly higher mortality rate in that peripartum period than a white baby would. The Hispanic baby would be much more likely to be born with low birth weight, would be small for gestational age than their white counterpart baby. If they were Asian American Pacific Islander baby that I was giving birth to, their mom would have a high likelihood of having a postpartum hemorrhage and bleeding after the delivery, having problems with the uterus and severe lacerations after that delivery. And if it was a Black infant, that infant would be 4 times as likely to die from complications related to low birth weight, would have a significantly higher mortality as an infant in that first year of life than all of the other babies. And so when you think about that, everyone has the same hopes, the same dreams, the same goals for their child, but then the opportunity is not necessarily the same because of how our system has enabled and allowed for health equity inequities to be amplified. So what that means to me is that health equity is really us, not accepting, as Christine said, not accepting those babies being marked at birth, and thinking about how do we make sure that everybody has the opportunity to have the fullest health potential possible, and that we eliminate whatever is unnecessary, whatever is avoidable, whatever is unjust that leads to differences in healthcare. And sometimes that will mean addressing where people live, systemic factors like racism, discrimination, and oppression for different groups. And sometimes will mean addressing some of the conditions in which you are working, living, and playing, like social determinants of health. Because if we look at those babies down the line, we also know that not only do they have those challenges as babies as they grow, those groups that I mentioned, the Native American, American Indian, Indigenous adult, the Latinx adult, the Asian American Pacific Islander adult, the Black African American adult will also have complications and disparities that will shorten their lifespan or make their lives more complicated as they grow older. So we've got to do something about that. And the reason why it's important to really put this in context is that it doesn't really make sense when you think about the rest of the greatness of our nation. When we look at the United States compared to all of its other Western counterparts or other industrialized peers, we score one of the lowest in life expectancy, one of the worst out of 34 countries. I think we're 33rd or 32nd in infant mortality. And we're last or near the last in access, in administrative efficiency, and equity and health outcomes. And Jose Escarce at UCLA has often said, by any measure in the United States, we have a level of health inequity that's rarely seen among developed nations. And so we have to figure out, how do we address those deep roots and change the course of life and break that cycle for the babies that I'm talking about. To do that, we need to do a few things. We need to actually think about what is at the heart of health inequities. I know a lot of times when we look at things like COVID-19 deaths, which we've all been looking at, we've been sobered. It's been sobering to actually think about the fact that we hit 5 million deaths recently, and that is an absolutely difficult landmark in our nation's history that we're going to have to contend with, and we're going to be feeling the effects of for years to come. When we see the disparate effect of COVID-19 on communities of color across the country, on communities that have been disenfranchised or marginalized, underserved, we see that. And we see that, and I believe that those things like COVID-19 deaths, asthma-related outcomes, morbidity and mortality, disparities in heart disease, those are all things that we see, and we talk about them as downstream things. Those are the results of things that have happened. So you've got to ask yourself, well, why that? Why did the COVID-19 pandemic decimate communities of color across the country and poor communities? Why did that happen? So you got to get, that 5 why exercise. You got to keep asking why. And when you start to ask why a little bit more, you realize that we have challenges like, crowded housing conditions, food insecurity, educational barriers, unemployment, income inequality, toxic exposures for children with asthma. Those are the things that are maybe more midstream. But if you can push yourself a little bit further to say, well, why do we have that? Why do we have those? The answers then become, well, there are a lot of other reasons why we have those, and we have to be willing to go further upstream to address those problems, and talking about things that are historically difficult for us to talk about, things like racism, things like poverty, things like discrimination, things like othering, and making groups of different racial, ethnic, sexual orientation, gender identity, religious, veteran, ability statuses, making people feel like they are others and therefore less than deserving of the best health and the best care and opportunity. So I think a lot of my work has been informed by this quadruple aim, and thinking about that as an aim for improvement. I think you're all familiar with the triple aim, which is first put into our lexicon by Dr. Don Berwick in 2008 or so, talking about those aims that we needed to have as a North Star for our health system as we were going to make it better and be able to deliver really great experiences for populations, for patients, and for our kind of GDP, where we spend a lot of money on our costs and on our healthcare. But in 2014, Dr. Tom Bodenheimer and Dr. Krasinski published the quadruple aim and added this other piece, which is caring for the team that's taking care of the patients that we have in our system. And I think it was really important to think about the clinician experience of all of you on the front lines of delivering care as a very important aim that we must focus on, because we can't achieve the other three if those are not true. But then fast forward to 2020, when we had obviously the combination of this deadly virus, the coronavirus, and the COVID-19 pandemic that hit us, and then and coupled that with the the observation and people actually witnessing the tragic and unfortunate and unnecessary murder of George Floyd on video, and watching for over 9 minutes how that played out, having people be able to see those things at a time where we were actually at a standstill from the pandemic, really awakened something in people that had not necessarily been there. And the question now became, is that aim in healthcare sufficient? And every single industry, not just healthcare, was asking themselves that same question. How can we actually be responsive and and take a stance around injustice, but as it relates to our industry? And in the case of healthcare, it's how could healthcare ecosystems really apply a health equity approach to the way we're delivering care and what we're doing? And I think to do that, it becomes important to really think about health equity as central to any successful vision that we have for our nation's healthcare ecosystem. And so in 2021, my colleague, Dr. Mark Rostetter, and I, we put out an article, which I think was given to you in the pre-reads, that was really redefining the quadruple aim and thinking about how do we actually make health equity the center of the aim, and recognize that if we don't do that, if we will still allow some of the things that we know, when we think about, I like to talk about and open up with talking about babies, because I think those are the most kind of innocent, pure minds and people that we have. And when we think about those inequities, and we translate that to people down the line as adults, we can see the challenges that we have. And I think it's really important to think, how can we then make health equity central, the bullseye of the quadruple aim? What will it take to do that? And there are four things that I think that it will take for us to do that. One is certainly confronting the truths and the painful truths that we have in our nation, thinking about how we can precisely and accurately create interventions and programs and partnerships that will elevate communities with accuracy and not just kind of blanket solutions. The third is applying a health equity lens to all of the work that we do. And the fourth is aligning our incentives to support that work. Now, when we think about confronting truths, we've got to be really cognizant of the fact that there are a lot of historical actions, inactions, policies, and structures that have allowed what we saw with the COVID-19 pandemic to be inevitable. And so, how do we really take a moment and say we have got to be comfortable with reckoning with things that we have historically not been able to reckon with, that we have been uncomfortable talking about? We've got to be able to do that. And I think that we can. I think that we are. And I think that the dialogue has started to open up some wounds and be able to kind of confront some of the things that have been historically a challenge in the United States. I think we also have to think about the accuracy and precision that I mentioned. And we know that people think a lot of times that, well, if we just globally improve the way we deliver care, we will address disparities. Well, what we've seen in the quality improvement literature has been pretty consistent about the fact that when we make global improvements to the quality of care that we deliver, what we do if we have disparities is that we might improve things for all, but the disparities still exist because the people that have been largely on the margins have not been brought to the center. And if we're thinking about things that will improve the health of people globally, but not the ones that are on the margins, we'll never really mitigate those disparities. So thinking about how do we accurately create programs, opportunities, partnerships that will really move people from the margins to the center. And then the third thing is the bringing a health equity lens into everything that we do. And that lens will require a lot of attention and detail, but we can do it. We have to think about how do we look at people and how do we analyze people based on demographics, understanding how we disaggregate data so we can understand what is the impact or what are the outcomes that we're seeing based on zip code, based on race and ethnicity, based on sexual orientation and gender identity, based on being a veteran, based on abilities or disabilities. How do we analyze to that level of detail so we can really create things that will work and that will be specific enough to improve the health of different groups? How do we also shift and realign power and trust some power and some opportunity to communities that have historically been disenfranchised and underserved, and learn from them? Because I think what you know, when if any of you have done community engagement work or community health work, you know that a lot of times the solutions that we're looking for, they are sitting in the communities that we're taking care of, communities that have been disenfranchised in population and marginalized. You can go and have great community conversations, and I've been in so many conversations where people will say, well, this is what I think we need to do. And they've got the answer. We just have not a lot of times afforded them the power to be to have a seat at the decision making table. So just being able to do that is really, really important. And then, thinking about how do you kind of continue to ask those whys, those 5 whys. Well, we see this, but why? Because this has happened. Well, why did that happen? And why did this happen? And of course, if you have little children, you know that when they do that, sometimes that can be a challenge when they're asking you why. But if we apply that same kind of rigor to the work that we do, I think we'll get at the roots of the problem and therefore some of the solutions. And then finally, thinking about how do we align incentives. So what really is the incentive for anybody to give up the privileges that they have? How do we design a healthcare ecosystem in which we are capitalizing on the opportunity to create an ecosystem in which we all are responsible for each other, and we feel that there's a moral imperative for us to care about the challenges that people in communities that are maybe are not similar to ours or not like ours. There's a moral imperative there, and Dr. Don Berwick wrote about that during the pandemic. I think is really important for us to think about, because what we saw with the pandemic is that one cough matters. If someone is coughing 3,000 miles away from you and they've got the virus, we saw that we could not escape our neighborhoods of privilege, our domains and bubbles that we lived in. With a global pandemic and a virus like this, we could not really escape the challenges that someone experiences far away from us. So we have to really see ourselves as a global community that is responsible for the health and the health outcomes of people around us. So some of the work that we're doing and I'm focused on at Humana is disaggregating our data, better understanding how different populations look, what are experiences of different populations, how can we make sure that we provide enough data to understand how we target and design our solutions at every step of the journey of your consumer, whether that's a person receiving care in one of your clinics or someone that's engaging with you as in our case, as sometimes as a member or plan holder. What does that journey look like? How do we create a journey in which the experience is free of bias, that we're mitigating biases that we have, that it's culturally competent, that it's culturally inclusive, that it's linguistically competent and inclusive at every single step, and that we are addressing the social needs that people have and some of the social barriers to full health, the social determinants of health that actually influence health much more significantly than anything we do in our offices and our practices. And then also I'm working really hard on leveraging artificial intelligence to predict where we might have challenges and be able to intervene and co-create solutions with our foundation, which does a lot of work in our community with our population health team, and also think about how we bring all of those things together to create a really robust ecosystem that's focused on equity. So honestly, to wrap up here, just think about the work that you do every day is so important. You've already committed yourselves to taking care of people who have largely been on the margins. It's a responsibility for the rest of us in the ecosystem to center those folks and what we call centering at the margins. Like, how do we make sure that the work that you're doing on the front lines is complementing the work that we're doing in the other parts of the ecosystem to create the best system of care? Because what we do really for the least and the least privileged among us is really going to have implications for what we do with the most privileged. And so I hope that as we're thinking about how we co-create solutions, how we bring together all these other parts of the health ecosystem, that we will explicitly and unabashedly and without apology centralize health equity and make that truly the bullseye of our quadruple aim.
Welcome to the opening panel of the Americares Health Equity Summit. My name is Rashad Massoud. I'm the Senior Vice President and Chief Program Officer at Americares. I'm thrilled to moderate the summit's opening panel, appropriately focused on health equity at a broad level. Today, you'll hear from experts on topics like mental health, climate and medicine security equity, but right now I'm honored to introduce an incredible panel. First, we welcome Tiffany Benjamin. Ms. Benjamin is Senior Director, Social Impact, and President of the Eli Lilly and Company Foundation. In this role, she manages the company's corporate social responsibility efforts, disaster relief efforts, global health initiatives, environmental, social, and governance strategy, and community civic engagement. In 2020, she led the company's global philanthropic efforts in response to the COVID-19 pandemic, as well as its philanthropic efforts to address racial inequity in the United States. We are grateful to Tiffany and Eli Lilly for many years of partnership with Americares, including a collaborative program that connects low-income patients with diabetes to resources that will help them obtain care, medicine, and supplies. Welcome, Tiffany.
Thank you.
Next, we welcome Brianna Lathrop. Ms. Lathrop is the Chief Operating Officer and Nurse Practitioner at Good Samaritan Health in Atlanta, Georgia, where she provides executive leadership and direct patient care. She has spent over 15 years providing healthcare to individuals and families who lack health insurance. Brianna writes, speaks, and teaches and provides consulting services on topics of health equity and social determinants of health. She is the co-author of How Neighborhoods Make Us Sick, Restoring Health and Wellness to Our Communities, and is a Robert Wood Johnson Foundation Culture of Health leader. Brianna and Good Samaritan Health Center are also wonderful friends and partners to Americares. Finally, once again, we welcome Dr. J. Nwando Olaiwola and thank her for bringing her expertise to this summit. I also want, on a personal note, to congratulate you, Nwando, on your recent election to the National Academy of Medicine. We are looking forward to hearing more from you in this panel discussion. Welcome all. As we just heard from Dr. Olaiwola in her remarks, we are in a moment where we have the opportunity and responsibility to put health equity at the center of the discussion. To continue in this vein, I want to ask each of you, from your position and perspective, how do you understand health equity in your work? Let me start with Tiffany, please.
Yeah, so we have been thinking about health equity for a really long time. And I think what Wando said a little bit earlier is a really powerful way to talk about it, bringing people from the margins into the center of the conversation. What equity means is making sure that everybody has an experience that is fair. I can speak as a Black woman who has existed in the healthcare system about the challenges you can face and the relationships you can have with healthcare systems and with the healthcare structure overall and how challenging that can be. But at Lilly, our focus has really been on ensuring that patients can get access, ensuring that our clinical trials are set up such that we are representing populations that include marginalized communities, but also thinking about, are we making sure that we are listening to communities in terms of what healthcare matters to them and what they value, and figuring out how we respond as opposed to imposing our opinion on them. So I think, to me, the definition of health equity really sits in the hands of each and every community. And it's our job as partners of communities to listen to what they think equity means.
Thank you. If I can turn to Brianna and ask you, how do you understand health equity in your work?
Yes, Good Samaritan Health Center is a charitable care clinic in Atlanta, Georgia. And there are about 1,400 clinics like ours across the U.S. In addition, there are hundreds, thousands of federally qualified health centers, which, along with our emergency rooms, really make up kind of the safety net of healthcare here in the U.S. And the majority of our patients do not have health insurance. Some of them have Medicaid and Medicare. All of them are at 200% of the federal poverty level or below, and have historically, currently continue to be often excluded from the healthcare system. So our work is to deliver that care. And we do this by recognizing that health is not the same as medical care, and that when we center the health and the stories of our patients, it changes the way we deliver care in order to build equity, to give people a fair and just opportunity to live a healthy life. So this means that we talk to our patients about understanding them as individuals, that we screen for social determinants of health, and that we understand that our patients not only are more likely to not receive access to health services, but also likely to experience other negative social determinants of health, whether that be experiences of racism and oppression, experiencing homelessness or poverty, food and access, housing insecurity. That when we have conversations that center all of these needs, we deliver better care that can improve patient outcomes. It means we have a farm. It means we partner with people in the housing sector to help people get secure housing. And when we center these needs in the stories of our patients, it allows us to meet these social needs and move upstream in our approach to healthcare. And I always like to say that our patients are resilient, that they are engaged in their care, that they bring solutions and healing from their communities, but that their resiliency does not excuse the inadequacies of our healthcare system and the failures of our nation to create a space in which health equity is the reality. And so when we have opportunities to join with others, to have these conversations, to share our stories and our experiences, that in this way, we start to also build a conversation around how we change as a society, how we change our policies and our structures, so that the reality of what our clinic does, as well as clinics like ours across the US, doesn't look the same in 10 or 20 or 50 years, that we continue to rethink how we deliver care in a way that meets the needs of each community and each individual.
Thank you. That's wonderful. Nwanda, if I can come back to you, you defined health equity in your keynote. You've described the elements to progress. At this point, what do you think are some of the key barriers to progress?
Yeah, thank you. And I appreciate the comments of my two colleagues and both of your work tremendously. So thank you for all you do. I think that one thing is that I still have conversations in which we're still trying to kind of validate and make a case for the fact that health inequities exist. And I think that we've got to really get to a place where we're agreeing on that and then talking about the how and not the if that's true. I also think that we we haven't focused a lot on the other things that make people sick, and we're not sure who owns it. So I've been in conversations before where people say, well, okay, we're the primary care delivery space. One of Brianna's clinics, well, we'll do the primary care and the behavioral health and the dental services, and we'll do that. But once we get to the social needs, that is not our permission space, and that needs to be somewhere else. And I think that one of the biggest barriers standing in our way is that if we don't take care of the other thing, if we don't own some of that in the space where care is delivered, it won't necessarily get done, and we won't necessarily tap into the power of what we see in the care delivery space. And so what we're seeing as needing to continue to refill prescriptions for albuterol for breakthrough asthma or exacerbations is really a manifestation of something that's probably related to housing. And so we can't really divorce those things from each other. And until we're ready to kind of marry up those concepts of social needs of impacting health, I think we're going to continue to have challenges. I will say, though, fortunately, that we're seeing a lot more traction in the area of actually integrating the actual kind of clinical health with social health. But I think we have a long way to go.
Thank you. Tiffany, if I can ask you a question. In an earlier conversation you and I had, I was intrigued when you said the business side of it is what I do every day, but my passion is the community and the importance of community health workers. Can you speak to that a little bit more, please?
Yeah. So I like to think back when I took this role 3.5 years ago, my title was actually head of corporate social responsibility and global health, as well as the president of the foundation, the longest title on earth. And one of the first things I did is I looked at it and I said, well, I don't like the term responsibility because it implies it's something you feel obligated to do instead of it being something that's about what's important for the community. So one of the things I did very quickly is change the name of the organization to social impact. And that's because the impact of the work matters more powerfully than what you are actually doing, right? That's what really matters to me, is that you can have measurable impact and that the community feels like you're doing something of value to impact the community. And to me, I have a real passion about what you can learn from a community. I don't think I'm an expert. I do a lot of work in a lot of different communities, and I don't live in those communities. So I certainly wouldn't be an expert on the cultural norms of those communities, on what works best for them, on what their biggest challenges are. But the people who are experts are the people who live in those communities. So for me, work with community health workers is extremely important. We at Lilly have been doing that work for decades, and we have actually considered our global health equity work to be global. So we do community health worker work in Kenya, we do community health equity work in India, but we also do it in Indianapolis, Indiana, where our headquarters are. For us, it's really important that we understand that the community is the one that is driving for change, and our job is to just simply listen to them and support them in what they think is most important and how they can be most successful. It's a partnership, but we understand that we're number 2 on the list for that partnership, and the community is the most important part of it.
Thank you. Brianna, you've spoken passionately about knowledge sharing and the contextual adaptation of the evidence. Why is this important? How do you do it? Would you tell us a little bit more about that?
Sure. This really builds exactly on what Ms. Benjamin was just saying, that we're number 2 on the list. That whether we're working with a community on an intervention or whether we're in the exam room with an individual patient, that medicine has also been sort of hierarchical and power imbalanced in nature. There's this idea that certain people hold skill sets or degrees or abilities, and that they share or pass on that information to others. But in reality, if we want to address equity and we want to build equity and eliminate disparities, it's a two-way street, that I have to understand what my patients know about their lived experience, about their community, about their body, about what they need. And that as a provider, or whether we are in a community planning an intervention, that we listen to those needs. And it doesn't mean that quality assurance programs or evidence-based guidelines are no longer relevant. They certainly are. But we use that contextually within the lived experiences of the communities in which we work and of which we are a part. And that if we aren't talking about those larger social determinants of health in our conversations with patients and in our interventions, we might miss the most important step. If I am addressing a patient's diabetes and find out that she's lost access to her food benefit, her food stamps, and can't afford food, and I haven't asked those questions or connected her with a way to restore that, then we aren't going to make progress on any health condition. That this also means that not only do we change our approach in the exam room, but we also build clinical teams that allow for this knowledge sharing. I think community health workers are a great example. Another is we have a certified peer specialist, someone with lived experience of addiction and or mental health. And she shares a common language and experience that can connect with patients and help them rethink and set goals in a way that no number of degrees or years of experience for me will ever gain me. And that we come together with our team members, with our patients, to share that knowledge and know that there is not one knowledge that's more important than the other, with the exception being the individual is first and foremost centered in that care approach.
Thank you. Wando, if I may come back to you, could you tell us, why do you think the payers matter in this conversation, and how can they drive equity?
Yeah, that's a good question. It would be impossible for me to be in a panel where someone didn't ask me that. So I think it's important to address it. It's interesting because in my work, my obviously training in primary care and public health, I kind of knew early the importance of the payer, but never, this is my first experience actually being on this side of healthcare. But one of the things that I recognize as doing this is that, as I have grown in my career in the public health and health policy space, I realize that a lot of what we value is shown up in what we pay for and where we put our dollars, and how we spend and what we consider important. So in the role of a payer, you have a tremendous opportunity. One, you have access to just so many views of the patient. I remember being in my community health center days and wishing so badly that I would have more than a view of what happens in the primary care office. Like I would say, we don't know when they go to the emergency department. We don't have any information when they're admitted to the hospital. We don't have information on specialty care. Well, the payer has a view of all that. The payer has a view of all those places where people touch if they're insured. And so it does give you an opportunity to really understand kind of all those different pieces of the journey that a patient has throughout the healthcare ecosystem, and an enormous opportunity to start to predict and prevent future challenges. But when you think about what you pay for, we've been really creative at Humana. I've been really proud of the work of our population health and teams who have been thinking about how do we design benefits that address those very things that Brianna and Tiffany are talking about. Those other social factors that influence the way people get health. How do we kind of weave in what we're hearing from those community conversations into what we design in our benefits packages? And so we have programs for example, we have a food benefit, which is similar to, you've got your insurance card, you've got your prescription coverage, but you also have food coverage, and recognize that our communities and our members, our patients have told us these are the things that we have challenges with. We're experiencing food insecurity like never before, certainly with the pandemic that has exploded for families across the country. So how can we take our position as a payer and weave in things like food into the way we actually care for people? And you all know, but I love to share it. Jack Geiger, when he was in his early stages of forming the community health center movement, and used to write prescriptions for food, and people would go in the rural towns to the pharmacies and say, "Here's my prescription from the doctor, and it's for food." And when they came to kind of knock him down and shut down his business, they said, "Why are you writing prescriptions for food for people?" And he said, "The last time I checked, the cure for malnutrition was food," and that was kind of where he kind of hung his hat in the early days of this movement. And so I would say that the same thing really holds true when people are telling you that, yes, I want to take care of my diabetes. Yes, I want to take care of my hypertension. Yes, I want to prevent cardiovascular disease, but I'm hungry and I need food. I need food security. I need healthy food. Then we as payers can design benefits around food. And we're doing similar things in housing investments. We're doing similar things with transportation investments. And so I think that the role of the payer is really reconfiguring what the traditional benefit landscape looks like and expanding it to include things that really will impact social health.
Thank you. Nwando, just one follow-up question, like maybe in 30 seconds, because we're running out of time. Why is this personal to you?
Yeah, well, I mean, I will say that I've had as a child of immigrants, and coming from an immigrant family, having seen kind of the gross maltreatment of family members of mine, either because they were immigrants and maybe didn't have English as a first language, or my own personal experiences as a patient, as Tiffany alluded to earlier, being an African American woman going through the process of maternal care, and some of my own personal and very real experiences with racism in the healthcare system, even with all the other things that I had that could have been buffers. It's not just an abstract concept or challenge for me. It's really something that's real. And then being on the front lines of care in the community health center world, seeing the problems that people deal with every day, really kind of crystallized a lot of the work for me and have given me a lot of fuel for the work that I do now.
Thank you. This has been a very rich discussion, and we do appreciate you bringing your diversity of perspectives on this complex issue here today. From defining health equity to talking about the centrality of the community-led change and how to measure progress, and we'll need to develop a different framework than the other public health efforts, and how this has affected you personally in your lives. I want to thank each one of you for those insights and for joining us in this panel today. I'd like to thank you for all the amazing and urgent work that you're doing to advance health equity.
I am Erica Hill, and I'm thrilled to be moderating this next panel. So for the next 45 minutes, we're going to focus our discussion on health equity, on mental health. We often talk about the barriers to physical health care, and if you think about those barriers that exist, they are multiplied when we're talking about access to mental health services. Around the globe, 1 billion people are impacted by mental health issues. And mental illness, as we know, is a leading cause of disability. Just here in the United States alone, more than 43 million people are currently living with mental illness. Nearly half of those people, I should say, are living without treatment. And in developing countries, that treatment gap is significantly higher, 90% in many cases. And of course, this, like so much else, has only been made worse by the COVID-19 pandemic that we've all been living through. So as we talk about barriers to mental health and think about what they look like, it's probably good to think about your own experience. Mental health care typically is delivered by a specialist. Usually it's done in an office that is separate from wherever your primary care may be found. There can also be a lack of knowledge. As we know, there is a significant stigma surrounding mental health and mental illness. So maybe it's not even recognized. Maybe you don't even get that referral. So those are the barriers that we know of. Add to that the cost of additional services, cultural barriers, in addition to a severe shortage of providers. And that gives you a sense of what the challenges are when we look at mental health equity. So a couple of weeks ago, I was really fortunate to sit down and speak with a person who many would say is the leader when we talk about global mental health equity. Dr. Vikram Patel, he is the Pershing Square Professor of Global Health, and he's also a Wellcome Trust Principal Research Fellow in the Department of Global Health and Social Medicine at Harvard Medical School. And that's where he also heads up the Mental Health for All lab. He's a professor in the Department of Global Health and Population at the Harvard T.H. Chan School of Public Health and the co-founder of an Indian NGO, Sangat. And I think our discussion is really a great way to get us into the topic at hand today about mental health equity. So let's dive into that right now. Here's part of our conversation.
Dr. Patel, it's great to have you with us today. We're talking obviously about health equity. So at Americares, we believe that health equity is achieved when every person has a fair and just opportunity to live their healthiest life. I think oftentimes we hear health equity and we think about our physical health, sort of our traditional medical health. But I'm curious, what's your definition of mental health equity?
Well, thanks, Erica. So for me, quite simply, it's the same principle as health equity applied for physical health, but in this instance applied to the specific domain of mental health, which translates into the realization or the attainment of a similar high quality of mental health, regardless of one's station in life or one's social demographic characteristics. In reality, Erica, poor mental health is disproportionately experienced by low-income communities, historically disadvantaged and marginalized communities. And this is the inequity that we need to address while we simultaneously try to improve the mental health of the entire population.
Where do you think that inequity comes from? Is it solely an issue of economics, or is there more to it?
Well, I mean, definitely economics plays a very big role, but there is more to it. I think if you consider the risk factors for poor mental health as one example, such as adversities in one's early life experiences, people who live in low-income communities and other marginalized groups are likely to experience a much greater load of these adverse life experiences in childhood, which in turn, of course, increases the risk to develop mental health problems. Let's give another example, which is that access to good quality education is known to be one of the most protective factors for mental health. And again, it goes without saying that vulnerable, disadvantaged groups in the population have poorer access to quality education. And a third and final example is access to good quality care is so important to enable one to recover when one has a mental health problem. And again, these are the same groups that will have inequitable access to the kind of quality care that we know works.
So to that end, you have a real focus on what you refer to as a rights-based approach to care, which certainly comes into play when we're talking about mental health equity. Can you just share with our audience what you mean by that rights-based approach?
Well, I think that I think of rights. I mean, the word rights, I think, is self-explanatory. It's an entitlement that every citizen must have towards whatever public good we are talking about. In this case, that public good is mental health, and I want to frame it as a public good. So there are many different kinds of rights. The first is a right to be protected from known harms to our mental health, such as adversities in our childhood or exposure to violence. The second is the right to care of one's choice. And I want to emphasize one's choice because the low-income communities or minority groups are often denied the choice when there is such a choice for care, for example, between medication and psychotherapy. The third is a right to freedom. And that might sound a bit odd, but honestly, the numbers of individuals with mental illness who are incarcerated, I think, is a national crisis. But again, this right is enjoyed disproportionately in the population. An overwhelming number of people with mental illness who are incarcerated are people of color, for example, or come from low-income backgrounds. And finally, the right not to be discriminated against, for example, in school or in the workplace. I think these are just a set of fundamental rights, which I think everyone with mental health problems is entitled to, but that these rights are inequitably experienced by the very groups I mentioned earlier.
I do want to just pick up, you mentioned COVID and how COVID has exacerbated some issues. Can you just drill down on that a little bit? What do you see in terms of gaps and barriers to achieving mental health equity, and even to chipping away at that stigma and even the stereotypes that are out there? How has COVID made that either better or worse in your view?
So the pandemic, Erica, represents in my mind the world's first truly global humanitarian crisis. I can't think of any, at least in my lifetime, any crisis that has affected the entire global population at roughly the same time. Uncertainties and losses are major factors contributing to poor mental health. And if one considers the sheer breadth of uncertainties and losses and how long and enduring these have lasted, it's nearly been 2 years now. It is not at all surprising that experiences of poor mental health have become widespread. In my reading, these are mostly rational responses of our minds to the extraordinary circumstances that we're facing. That said, when you increase the population prevalence of distress, inevitably this will fuel an increase in the numbers of people who have clinically significant mental disorders. And what really worries me even more is that this increase will be amplified by the impact of the economic recession, which, as you know, affects different groups very disproportionately. A few of us have become fabulously wealthy, whereas large numbers of people have even lost their jobs. The widening of inequalities, the polarization that we see around issues like vaccination, and the continuing uncertainties about the future waves of the epidemic. I think all of these combined continue to bite into our mental health. The pandemic has also, I think, brought into sharp relief the structural inequalities that existed before the pandemic. And people who are already disadvantaged or vulnerable for one reason or the other, for example, young people, low-income groups, and people who had an existing mental disorders have been especially badly hit. How many people really know that comorbidity with mental illness, just like comorbidity with diabetes, greatly increases your risk of severe COVID or dying? I think this is an example of an established inequity that was there before the pandemic, which has been amplified by the pandemic.
So part of what you're doing, right? Part of your work is to look at solutions and to look at, in your current research, as you're prioritizing things, solutions that are out there that can work to help those dealing with mental health issues, to destigmatize, and to really bring this to the forefront. So I'm wondering if you could walk through, part of what you talked about, that one of the things that really stood out to me is developing and evaluating non-specialist provider delivered interventions. So we're not just talking about, in my understanding, psychiatrists, psychologists, for example, but expanding the group of those who could offer care when it comes to mental health. What does that look like?
So Erica, thanks for that question. This is, of course, goes to the heart of my own work. Let me start by saying that the most innovative healthcare delivery solution, which has emerged from global health, which is a euphemism for low resource parts of the world, is that of the task sharing of healthcare interventions with non-physician frontline providers. This has a long history, and it was initially championed for maternal and child health, and then subsequently for infectious diseases. But over the past decade, task sharing has been adapted for the delivery of mental health interventions. Just a couple of weeks ago, a large body of evidence, now nearly 100 randomized controlled trials from over 40 countries, was put together in a systematic review, which demonstrated the effectiveness of frontline worker delivered psychosocial interventions for the prevention and care of a range of mental health problems. This is probably the largest body of delivery science in my mind for the field of mental health, and I believe the most transformative of all. People often ask me, what's typical about these interventions? So these interventions are typically built around the building of specific psychological skills in the individual. They often address not just the psychological symptoms, but also the social determinants that we know often accompany mental health problems. They tend to be quite brief, and they're typically delivered in community settings or, of course, during the COVID era through telemedicine. But the global impact of this work has been enormous, Erica. This is now a kind of an innovation that is no longer, there's no equipoise, there's no question, does it work? It's now been embraced by all the major global policy institutions like the World Health Organization and many national policy instruments, such as, for example, here in the US. And to give you an example of how these innovations are coming to the US, a brief treatment for depression involving 6 sessions based on the principle of behavioral activation. It's one of the cognitive behavioral principles that was developed in India, has now been adapted for delivery to moms in Canada and the US, making this perhaps the first ever example of a mental health intervention developed in a low resource country being used here in the US. So to me, this is the most exciting thing. And I want to just end by saying something it keeps me awake day and night with excitement. And that is our attempts to scale up these innovations by building the workforce capacity of frontline workers, such as community health workers, nurses, social workers, and so on, to learn, master, and deliver psychological treatments through the initiative called Empower, which is launched at Harvard Medical School, which comprises a suite of digital tools to actually build the workforce. And just in June this year, thanks to the Lone Star Prize, we will be rolling out community health worker depression care in underserved communities of Texas over the next 4 years in partnership with the Meadows Mental Health Policy Institute and the University of Texas. And I'm hoping that the platform over the next few years will expand its suite of content to include anxiety problems, trauma, youth mental health problems, and harmful drinking.
So really quickly, because I know we're tight on time, this all sounds so exciting and so wonderful because we're expanding, right, the opportunities to provide more equitable care when it comes to mental health. We know how overwhelmed so many frontline workers are, healthcare workers in general, especially because of the pandemic. How does that training work? How much more is it adding to what they're already doing, and how receptive have they been?
Well, so far we found that people are so enthusiastic because these are providers who already engage with people around life problems, social determinants, and they often struggle then with the psychological symptoms that the people that they're supporting are experiencing. This empowers them literally to actually provide person-centered holistic care. Luckily, the people we're working with in Texas already have financing systems in place, but that is a very important issue. How do you scale up isn't just about training and supervising and supporting people, but also ensuring that they're adequately compensated. And I believe that the policy imperative is that the new funds that are being allocated to build back better our mental health care systems must include a significant allocation for actually compensating frontline workers for being the frontline, the frontline army for mental health care. And importantly, Erica, it's important to know we're talking about an extension of the existing mental health care system to expand its footprint into the community to reach those who historically have rarely accessed mental health care, while at the same time making sure that those who do need more specialized care can very quickly access it through referral by the frontline workers. So I want to be clear, we're not talking about a replacement of the mental health care system or a silo separate from the mental health care system, but actually an expansion of the mental health care system.
An expansion working in concert. It's so important. We could continue talking about this all afternoon. Unfortunately, I know we have to leave it there, but Dr. Vikram Patel, really appreciate your time and thank you for sharing some of your passion and your work with us today. And we look forward to continuing the conversation here.
Thank you, Erica.
It was so great to speak with Dr. Patel, and I'm glad that we were able to share that conversation with all of you, which sets us up so well for what's next as we continue to talk about not only what health equity means when we talk about mental health and access, but also what are the solutions out there. Of course, the goal is that with awareness comes action. So that's part of what we're discussing today. I want to introduce our panelists now. First up, Lisa Jones Chandler, who is Vice President of Corporate Excellence at Vibrant Emotional Health and also a specialist on equity within that organization. Vibrant Emotional Health works with individuals and families providing mental health services and also focuses on advocacy work to advance access. Lisa, it's great to have you with us today. Also
Thank
joining
you.
us, Dr. Dorianne Miller, who's professor of medicine and director of the Center for Community Health and Vitality at the University of Chicago. Dorianne serves the community in South Chicago and also works with the University of Chicago's ECHO program, which extends mental health expertise into communities in need. Great to see you again this afternoon. And also joining us, Dr. Glenn Goff, who's Senior Technical Advisor for Mental Health and Psychological Programs at Americares. So Glenn oversees Americares mental health programs globally, easy for me to say. Great to have all of you with us. And I just want to remind you, if you do have any questions, we'd be happy to take them at the end of the panel. So feel free to throw those out there. As we look at where we're at, I think you each have such a unique view of what some of the barriers are to access and to health equity, specifically when we talk about the barriers to mental health services. And you each have a unique view based on the communities that you serve, the communities that you're working with. And again, we can't get to solutions without first understanding what those challenges, what those problems are. So I thought that maybe we could touch on the barriers within the communities that you serve first. And so Dorianne, I'd like to start with you. I was really struck when this panel met in advance of the summit last week, as you were talking about just the wait for someone who may need behavioral health services can be as long as 10 months. And when we all think about if your barrier to care is this long waiting period, what's to say that you're going to still want to be there in 10 months? So talk us through a little bit about what the specific challenges are to that barrier and what you're seeing within the community.
Erica, thank you so much for the question. As I think about barriers to receiving mental health care in the community, not only is there an issue of capacity within the traditional mental health space, and that particularly for people who have serious mental illness, waits can be up to as long as 10 months in order to receive care in those settings. But there are also financial barriers as well, because many times people who have mental illness oftentimes are either uninsured or they have a public health insurance such as Medicaid, or they may be on a plan through the Affordable Care Act, and there may be limited capacity for the mental health system to take these patients in. As you mentioned before, I work on the south side of Chicago, and within the primary service area for University of Chicago Medicine, we have 6 of the 8 poorest communities within the city of Chicago that exist within our primary service area. And so thinking about how people would be supported through health insurance, as I said, many on Medicaid, many who are uninsured, along with these wait times, I think provide significant barriers to care. In addition to that, and I think it's something that Dr. Patel referred to in some of his comments, and one thing that's the theme of this conference, and that's the issue of health equity and thinking about some of the implications around both race and ethnicity. The ability to have someone that is serving you in a mental health capacity that understands the delivery of services within the context of your community, I think is very, very critical issue.
Absolutely, having a fulsome understanding, right, of where people are coming from makes such a difference. Lisa, access to services and care, I know is something that you deal with specifically as well. Give us a sense, what are some of the barriers that you're finding, especially as, I'm really struck by the work, not just with individuals, but with families as well, sort of, you're really bringing in a broader community.
Yes, thank you so much, Erica, for having me today. And I just want to say that, in addition to serving families and communities, Vibrant also is proud to administer the National Suicide Prevention Lifeline. And so it's a free confidential support line 24/7 that allows emotional support for people in distress or in crisis 24/7. And so some of the barriers we start to look at, especially in our Black, Brown, and Indigenous communities, is that we know what the barriers and disparities can look like in the healthcare system. There's a significant amount of distrust in healthcare. And so experience, unfortunately, has taught us that by having to go through this with different healthcare providers, we are not being fairly treated, even when we're advocating for our own healthcare. And so we need to really become advocates as it relates to getting or receiving medical or mental health treatment. And so part of why people access, let's say, a confidential crisis hotline is because it allows for confidentiality. It removes some of the stigma that so many people from marginalized populations tend to face. And they don't have to worry about being discriminated against or not getting their needs met, and can actually just be met where they are and get the services that they need to be okay.
I think increasingly too, the conversation around equity really does come back to meeting people where they are, which is really underscored by what you're doing. Glenn, as we look at too, Lisa just mentioned the distrust. There's also, I think, a really significant misunderstanding sometimes as to what care looks like, what it should look like, what it currently does look like, and part of that comes from what quote unquote care may have looked like in the past when it came to dealing with mental health concerns and mental health illness. So in terms of, Glenn, that barrier, this sort of knowledge gap about what mental health and mental illness really looks like and how it can be treated, I know that's one of the things that you're also focused on.
Yes, Erica, we're at Americares, we have mental health and psychosocial support programming in 10 countries, including the US and including Puerto Rico, and we're expanding into 12 countries next year. Globally, the treatment gap, or the ability for people to access good quality mental health or treatment care, is 85 to 95%. But that isn't the whole story. In a country like the US, who has a large cadre of mental health professionals, there is still a treatment gap for Black, Indigenous, and people of color of 70%. One large barrier that Americares is working on is stigma and discrimination of those suffering from a mental illness or in recovering from a large-scale disaster or conflict. One example would be with refugees. Americares works with Venezuelan migrants who have fled into Colombia. They're subjected to human trafficking, sexual exploitation, criminality, loss of life, which often has a long-term emotional and mental health consequence. In Colombia, 19 psychologists see more than 3,000 Venezuelan migrants each month in 9 different Americares clinics across the country. As you probably know, it's difficult or even impossible for refugees to access mental health or health services, but Americares is bridging that gap.
In terms of bridging some of the gaps, Dorian, when we talk about getting people access to care, there's often this physical barrier. So perhaps you go, you're in a clinic perhaps, or with your primary care doctor. Some of the patients that you may see who you work with in South Chicago, they're comfortable with you in that setting, in a doctor that they see for, what they think of as maybe their physical health. But when you have to go somewhere else, right, even if you have access to that care, but you have to go to another location, I know that creates additional access issues. So how could it change things if more services were brought together, and if there was more of an ability to treat the whole person, not just the physical person, but the emotional and behavioral health as well at the same time and in the same location?
Glad that you brought up this point, Erica, because I think that it's one of the reasons why we've been very happy to partner with Americares regarding the program that is called ECHO Chicago, which stands for Extensions in Community Health Outcomes. If I could just take a moment to talk about some of the work that we do in this space and why it's so important to think about ways in which we can incorporate more mental health services within the context of a primary care setting. As you mentioned before, I'm not a psychiatrist or a psychologist by training. I'm actually an internal medicine doctor, which is a doctor for adults. But throughout my career, I've seen a tremendous need for enhancing the delivery of mental health services within the primary care setting for many of the reasons that Dr. Patel mentioned in his comments, including being able to extend issues care into the community. Echo Chicago provides telementoring for community-based providers through case-based learning delivered in a setting that's actually very similar to this, high-grade video conferencing, where providers can gain not just knowledge and skills, but managing conditions, both for physical conditions as well as mental health conditions, and that they can translate this into practice with the support of their peers. In the University of Chicago, we started this program in 2010, and we were actually the first ECHO site to do this in an urban under-resourced setting. The program actually started in a rural setting through Dr. Sanjeev Arora at the University of New Mexico. And we're the longest running urban ECHO program in the world. We leverage these existing assets and we bring together Americares sites, we bring together community health centers and others where there is a real gap in terms of the ability to deliver mental health services in the community. And I mentioned that 10-month barrier in my comments a little while ago. But figuring out ways in which we can bring together doctors, advanced practice nurses, social workers, psychologists, in order to provide a network of care and really almost a mini system within the clinical setting where there can be warm referrals in one setting to another so that the patient essentially has one-stop shopping when he or she comes in. We also provide training. We ask for a way in which we can get a little bit of support from psychiatry, but it really does help to build the capacity, both in terms of knowledge and skills of those primary care providers from experts that are providing information, but also, and I think that this is something that's really important about the way that the ECHO program is organized. There's peer-to-peer communication around what takes place. And so it's not just me or my psychiatrist partner talking about ways in which we can do a better job of diagnosing and treating patients with mental illness, but it's also other clinics that can talk about what types of approaches they've taken in their patient population. And so it provides for a peer-to-peer learning platform. And so everybody can see one another, can hear one another. We do case presentations within the Echo Chicago platform. And so we are able to better integrate evidence-based practice into care, and patients are able to receive state-of-the-art care in their primary medical home. For anyone who's interested in following us on social media, our Twitter handle is @EchoChicago. So just a little bit of a plug for us, and I'm happy to communicate about our programming perhaps a little bit later with the conference participants.
You know, as we talk about the experience that each of you has within your communities, how you've addressed these barriers, how you're sharing that information. I can't help but think of at the very beginning of the pandemic, a number of doctors I was speaking with who were on the front lines were talking about how they'd always sort of shared best practices, but this felt unprecedented because everybody was approaching this one problem together. And what strikes me is just how important it is to bring that knowledge together that we're seeing from each of the three of you. And Lisa, when I think about the crisis lines, and you think about how this really opens up an option for so many people, how have you seen the response to that grow, and even the comfort level that some people may have in accessing care simply by picking up the phone or by sending a text?
Sure, thank you. I mean, like we've said before, right? The pandemic has really shed a light on all that we need to really pay attention to and look at in this global humanitarian crisis that we're all collectively experiencing together. And when I think about the beauty of having a crisis hotline in these instances where we were forced to huckle down and not go out, the crisis line really became an important lifeline for many people in distress. And it allowed us to reach and assess people that we could not before, or maybe people who were hesitant to reach out, who had seen our phone number across the media and were hesitant to call and get the help that they needed. And when you think about why people call a hotline, I touched on earlier about the stigma that Black, Brown, and Indigenous people and folks from other marginalized groups face. You think about the opportunity to help them in real time and also introduce them to community health workers, paint the picture for what they can look to expect when they're able to go out and get an in-person visit again. What will it look like? Many people don't know, and you don't know what you don't know, but sometimes people are too hesitant or even afraid to ask. And so calling a hotline and having that anonymous feature, or even maybe three-waying with a friend or family member when a person is in crisis, is a wonderful way to reach our community and serve people and help bring down the potential crisis, and even potentially eliminate the need for a higher level of intervention.
I love the point that you made about, and I'm paraphrasing here, so I'm not going to say it nearly as well, but basically having a sense of knowing what you could expect in that care, right? And giving the patient who is looking for help, who is looking for care, a better sense of what they may be walking into. And Glenn, I wonder how much that comes into play, right? And maybe the situation in Colombia with the Venezuelan refugees is a perfect example, but helping to set the expectation, not just for what everyone, right? Everyone's right to have access to quality health care, that equity, both physical and mental health, but also, the expectations of the patients as they're coming in, and if they are in need of mental health services, setting their expectations, which also adds a comfort level for them as they're in many ways perhaps moving into uncharted territory.
Right, Erica. It is difficult for patients who are trying to access mental health services, especially globally. There are critical links such as psychotherapy by psychologists, case management by social workers, that just often does not exist. Another example, in Malawi, there's 5 psychiatrists for 16 million people, and a good comparison would be New York State, that has 5,000 mental health workers for 20 million people. So we work in that area between the physician, the psychiatrist, and the patient with almost no professional psychosocial support. And by Americares providing critical training for non-specialists that Dr. Patel mentioned, like nurses and community health workers, we can start to bridge that treatment gap. Let me give you an example also in Malawi. Recently, a 21-year-old university student in his final year came to one of our trained nurses. He was confused, hearing voices, distracted, anxious. Being an orphan and not connected to his family, he wanted to run away. But fortunately, his aunt brought him to the nurse. And using Americares training, the nurse calms him down and probes about what might be the cause of the voices, and starts a therapeutic relationship with him that helped him gradually to get better. Now, of course, Erica, we would hope that there would be both medications and therapy available, but for most of the world, these strategies don't exist.
When we look at where we're at, we know how COVID has impacted every aspect of our lives. I wonder, and maybe Doreen, you've seen some of this, maybe you haven't, if there have been any positives out of that, in that the conversation is perhaps coming more easily as we talk about caring for the whole person, and in recognizing that these are challenges that are being felt across the board, as we know in certain communities being felt far more than others, but still there is an impact, and certainly on emotional and mental well-being. Has that helped to open up the conversation? Have you noticed?
I think that the issues that people are facing now has helped to open up the conversation to some extent, because it's not just a question of dealing with a a pandemic across the world, but also other issues as well. And I think that Dr. Patel's comments spoke to this. He talked about some of the issues around the economic stressors that people are facing. Discrimination in the workplace, discrimination in just day-to-day settings. And it's not just a question of, I primarily care for African Americans in my community, but thinking about the violence towards Asians in our community, particularly East Asians, around the pandemic. I also think about the issue of some of the killings that have taken place within communities. I think about George Floyd, Ahmaud Arbery, Breonna Taylor, and others. I have one colleague who refers to this as a syndemic, which is the combination of pandemics coming together and having a synergistic effect in terms of how it's impacting people's lives on a day-to-day basis. Some of the things that we would normally do in order to help to comfort ourselves in terms of a sense of community, we've also been missing because we have been isolated from one another for public health reasons. And that's as simple as going to a funeral and being able to comfort one another and to grieve and to mourn together. And so many of these rituals, I think that we've missed. It's giving us opportunities to rethink how we interact with one another, but for some communities, particularly communities that may have issues around lack of access to technology, thinking about Zoom calls don't necessarily are not a great substitute for someone being in the same room with one another, providing that one-on-one support, that those types of things I think are missing. And so the types of alternatives and things that both Lisa spoke about as well as Glenn, doing interactions and interventions that take place throughout community members and not just within a healthcare delivery setting, I think are so important as we address these many pandemics that we're seeing in our society.
There's also a question, Lisa, of resiliency. And I think for so many people who have been disproportionately impacted by this pandemic, finding a space for that and even having that conversation can be really tough for a number of reasons that we know, and including what Dorian just laid out. I'm wondering, Lisa, what you're seeing in terms of how often resiliency, right, and the need to feel that you have some control over where you are, how that's impacting what you're hearing and what you're seeing in terms of needs.
Absolutely. I'm so glad you asked this question, right? We've talked about this theme of stigma and discrimination for certain groups in this country. And what we really don't talk about is our pull for survival and how much of it is in our DNA. And sometimes that in itself can be exhausting. We know that the support that people receive can vary and differ based on their race. And why building empathy can disrupt the impact of systemic racism is important for us all to keep in mind as health providers in this world as we support each other through this collective traumatic time. And so when we talk about stigma and discrimination, we have to also understand the impact it can have on Black and Brown Indigenous communities and how people's mental health and well-being can be affected by this. And I want to touch a little bit briefly on advocacy because as a result of that, of what we're seeing and what we've been highlighting on a national federal level, I'm not sure who are all aware, but Vibrant also has won the grant to administer a Congress and FCC designated line called 98 that will be launching next summer across the country. And it will be a universal 3-digit dialing code for the Lifeline in recognition of the need to increase accessibility of these life-saving services to everyone who needs it. And so while the nationwide availability is not slated until next summer, the Lifeline and mental health resources are available now by contacting the National Suicide Prevention Lifeline at 1-800-273-TALK. And just to highlight that 988 coming next summer is not just a telephone number for the Lifeline. It really represents a unique opportunity on how we change and deliver services for all impacted and in emotional distress. We have to keep that at the heart of this, especially with COVID in the backdrop of what we're all experiencing.
Yeah, Absolutely, keeping that focus right where it needs to be, keeping that conversation at the forefront to help reduce the stigma, to talk about the access, to let people know the resources that are out there. Glenn, as we watch all of this, the approach can be so different depending on the country where we're at, as we know, and even just highlighting the number of providers who are available. I'm wondering globally what you're seeing in terms of access to mental health services in terms of equity. Is the conversation starting to change at all? And if so, where are some areas that you feel there is more progress being made?
Well, Erica, there definitely is progress being made. But, as a result of the pandemic, there was an increase of 76 million extra cases of anxiety, 53 million extra cases of depression, not to mention the large increases of burnout and stress for millions of workers, students, and family members. So that's made our job more difficult. But at Americares, we are really getting back to, working with large cadres of community health workers, nurses, doctors, really anyone we can, train, build capacity with the departments of health, the ministries of health in numbers of countries. And there's such a hunger for the capacity building and training that we offer. And we see with the stigma and discrimination that, just excludes and isolates people. We're really working in that area as well. A third area also is just a lack of safety and protection and human rights for those with mental illness. And Dr. Patel really spoke to this quite eloquently. But if there's no safety or guarding of human rights, people won't talk and won't be able to work toward wellness. So we had in the Philippines, for example, our rural mental health network has actually helped families to decide to have their relatives released from harsh restraints and institutionalized care in favor of community-based programs. So right across the world, we're working with the WHO, with other NGOs, our colleagues, of course, Dorian and the ECHO program that's working so well with us to help the free and charitable clinics across the United States. So we're really looking forward to countering the inequities that are there, and look forward to it.
Key to countering those inequities, I think it's changing the definition of what health is. And Dorian, when we all met ahead of the panel, you brought up the definition of health in the World Health Organization from 1946. And I was struck by how simple and how important that definition was. I'm going to put you on the spot, hoping that you have it with you. But I think it also sums up one of the reasons that we're talking specifically about equity that's partitioned between physical health and mental health is because when we say the word health in general, I think it's about your physical well-being. It's not about the whole person.
Thanks, Erica. The definition that Erica asked me to share with you is health is the complete presence of physical, mental, and social well-being, not merely the absence of disease or infirmity. And so I think that definition is a very encompassing, holistic approach to health. And I think that many of the things that we've discussed today, and particularly in Dr. Patel's comments, are very apropos and encapsulate that statement quite well.
Yeah, it makes me think of that rights-based approach, which, I asked him to define it, and he's right. It is fairly self-explanatory. But Lisa, it's interesting. It seems that there can often be a barrier, a different barrier that goes up the minute there's a conversation about the right to healthcare, the right to access to equitable, quality healthcare. Are you seeing a change at all in that conversation? Is it, for better or for worse?
Yes,
Sorry, Lisa, that was for you.
absolutely. Even no, sorry, it's okay. Absolutely. At varying call centers, the crisis call counselors are experiencing this on a daily basis. People are calling in wanting to talk about how they're feeling and how they're doing and how, systemic racism and discrimination is impacting their daily lives and feeling like they have a space to be able to even talk about this out loud. There's so much we hold inside and in our bodies, and it ends up coming out in varying ways. And so our crisis counselors are reaching out to us to say, hey, people want to talk about this now. We're seeing an uptake in people wanting to share their experiences within the healthcare system and how we can do better as healthcare providers and leaders in this space by affirming and acknowledging where people are. And by taking a closer and deeper look into who benefits and who is harmed, you can then use that to give you a well-rounded approach to inform more fair treatment to ensure that everyone gets the support that they need.
Absolutely. Coming back to awareness can bring us to action, but we can't get there. We can't get to those solutions without first recognizing, admitting the challenges, the barriers, the problems that are there. Thank you all for taking the time to join us today. Thank you for the work that you are each doing individually and with your organizations to, do your best to break down some of these barriers, to break down the barrier of the stigma surrounding mental health, and to improve access to care and health equity for the whole person. It's really been a pleasure to be with you all today. Thanks so much.
I am Stephanie Kaufman with Americares, and it is a great honor and privilege to be having a conversation around medicine security. Medicine security means that every clinic, every health worker, and every patient, everyone around the world would have reliable, equitable access to the medicine and supplies they need to achieve good health. But to achieve medicine security, Americares believes communities need medicine accessibility, availability, affordability, and acceptability. Communities without any of these four components can be medicine insecure. But more commonly, these pieces interact, and often they are underscored by individual poverty. Nearly 2 billion people have no access to basic medicines. That means quality essential medicines are unavailable, unaffordable, inaccessible, or unacceptable for a quarter of the global population. Today, we will be discussing bringing equity to medicine access. So let's meet our panel. Joining us today is Americare's Chief Medical Officer, Dr. Julie Varghese. As Chief Medical Officer and Vice President of Americare's Technical Unit, Julie supports Americare's work to increase access to quality medicine for low-income and uninsured patients worldwide. Welcome, Dr. Varghese. Next up, joining us from Pfizer is Julie Jensen, who is the Director of International Product Donations as part of Pfizer Global Health and Patient Access. Julie leads Pfizer's strategy for international medicine and vaccine donations, including investments in global health delivery. Julie is also responsible for Pfizer's flagship donation programs and the company's response to humanitarian emergencies. Welcome, Julie. And also joining us from Ghana is Samuel Akufo, Ghana Country Operations Lead at Zipline, an innovative company who is shipping medicines and supplies through autonomous aircraft delivery. Samuel leads the health and fulfillment teams across all Zipline distribution centers in Ghana. He provides direction and guidance in operation excellence, stakeholder management, customer experience, and people management. Welcome, Samuel. So, what I'd like to do to kick off this conversation is at the onset of what I mentioned was I've given you Americare's definition of medicine security, but I would welcome the opportunity to hear from you as to what medicine security means to you and why is it so important now. So why don't we kick off the conversation with Dr. Varghese? Over to you.
Thanks, Stephanie. I would say that I view medicine security from a few different perspectives. As a physician, I've been really fortunate to have the opportunity to care for people in a variety of contexts. So here in the US, I've been a part of the free clinic sector, the federally qualified health centers. And just prior to joining Americares, I was actually in a private practice medical group in Connecticut. And, at least a couple times a week in my private practice group, I was having conversations with my patients about how they weren't able to afford their medications or not able to take them the way it was being recommended or prescribed. And so, when I think about being here practicing medicine in Fairfield County, one of the most affluent counties, in the US, and also with a high health literacy rate, that really reiterates the issue around medicine security, here in the US, and we've heard a lot about that throughout the other sessions. Similarly, I've been able to work in other under-resourced settings like India or in rural Haiti. And in addition to that affordability piece, there's so many factors around accessibility or ongoing availability. And so when I think about, practicing medicine here in my own backyard, so to speak, and halfway around the world, that same core issue around medicine security or lack of medicine security really is so central to patients' ability to be healthy or my own ability to provide quality care. When I think about medicine security on a broader level and health being so fundamental to everything that an individual needs to be healthy, to live a productive life and contribute to their community, I really don't think that you can separate medicine security from health as a human right or from health equity. Similarly, we heard in the earlier sessions, you can't really separate clinical health from social health. And so I think that medicine security really underpins so many of these broader topics. In terms of how Americares got to this work around medicine security, we've been delivering medications for over 40 years to our healthcare partners around the world. But there's so much beyond just the availability of medicines and getting medicines to the countries where we work. There's broader health systems factors that our health center partners are dealing with every day and that their communities are dealing with, whether that's transportation or health literacy, health centers with staff shortages. And so we wanted to find a way to really reflect all of those different factors that affect one's ability to be healthy and access those medicines. And so we've done a lot of strategic work, both with internal stakeholders and some key external stakeholders, and really found that medicine security was that overarching concept that helped to bring all of those different factors together.
Great. Thank you, Dr. Varghese. I'm now going to pass it over to you, Julie. I'd love to get your perspective in terms of what medicine security means to you, and particularly in the context of the work that you do at Pfizer.
Well, first, thank you so much, Stephanie, for inviting me to join this panel. And thank you to Americares. Pfizer is a long-term, very proud supporter of Americares. So it's great to see you convening such an incredible gathering on health equity. So on medicine security, I have to be honest, this is not really a term that I've used regularly. Normally, within our context, we talk about access to medicines, we talk about health system strengthening. But as I was thinking about this term, I really like it because some of those other terminologies can be a bit vague. And this is very much laser focused on what do we need to do to get this treatment to a patient. It's really, we talk about following the pill. And as Dr. Varghese was saying, what are all of those things that need to be in place in order for that to happen? And so as part of my role at Pfizer, I sit on the patient access and social impact team. And first, of course, we're thinking about access to medicine. We're thinking about affordability. We're thinking about the piece that we spend all of our days at Pfizer thinking about. But then there's the other investments that need to be made. So our team is responsible for how do we deploy our people and our resources, our technical resources to help strengthen, in this case, that secure supply chain for medicines. How do we deploy our capital, our investments to help build those health systems? And then, of course, how do we make the medicine available? So I think the medicine security term is really interesting. And I think as we talk about it today, just understanding all of the things that have to be in place for equitable access and distribution to medicines. Thank you.
Great. Thanks. And now, Samuel, would love to get your perspective through the work that you're doing with Zipline and just the work that you do in Ghana.
Yes, thank you, Stephanie. To me, medicine security exists when clients can obtain and use essential health commodities when and where they need them. And the two key words in here is when and where they need them. And this tends to strongly throw more emphasis on not just access, but also reliability and the criticality of supply, which is directly linked to what we do as Zipline, which is making sure that every single human has instant access to medications when exactly they need them. With respect to reliability, when a population receives medicines intermittently and there isn't any guarantee of the next period of availability, it raises issues of supply reliability, and ultimately then the term medicine insecurity comes in. And for patients living with chronic conditions who need these critical medications to survive, it becomes a major blocker for them to achieve their health outcomes. When you're talking about the issue of criticality, which is to me the where, in a case where medicine is needed critically during an emergency or a life-threatening situation, the only time and place it is really needed is that particular moment and location where it is critical, and it may be available at another location where it may have no clear immediate use, but not being able to have it where you need it the most raises issues of medical insecurity. And this concept also to me is directly linked to access and equity in a very clear way. Access, which has to do with people within their reasonable means being able to get medicines they need to achieve their health outcomes, and equity being an issue of fairness. Health systems generally must dig deeper to take into cognizance the differences we have in populations and patient requirements, locations. You have people living in rural areas and urban areas. Physical access to could also be a problem, and some of the other key indicators that would help us be able to achieve universal access needs to generally be looked at, and all that plays a role when they're talking about medicine insecurity. Actually, WHO in the past came up with what we call the EML, which is the Emergency Medicines List, some years ago, which looks holistically at policy, quality, access, and rational use. I think it is even more pertinent now that we are in the pandemic, when global supply chains have been interrupted and is not as reliable and movement is restricted. Medicine access could definitely be affected. Again, with a shift in focus to COVID-19 vaccinations and the need to vaccinate populations around the world, we need to get more creative around how we can still ensure there's available resources, and the available resources we have are not really stretched thin to affect medicine security.
That's great. Well, we're definitely going to be talking about global supply chain issues a little later on in our conversation today. But I don't think that we can be having a conversation about medicine security without having a conversation around vaccine equity. And so we know that safe and effective COVID-19 vaccines were developed in record time. These vaccines really do offer us as a global community the best hope for slowing the coronavirus pandemic and, of course, saving lives. But the virus is moving faster than the global distribution of vaccines. The majority of COVID vaccines have been administered in high and upper income countries around the world. But as new variants of concern start to continue to be out there, it means that the risks of infection have increased for people who have not yet been protected by vaccination. So the World Health Organization has a goal of vaccinating at least 70% of the population, the global population, by mid 2022. But how are we going to get there when there's so many challenges in terms of that vaccine distribution process? So I want to give this one, start this off to you, Julie. How do we get there in terms of trying to meet that 70%, WHO benchmark, and then how do we think about the equitable distribution of COVID-19 vaccines?
Great. Well, thank you. So back in March 2020, our CEO told us that we need to make the impossible possible. And we have been striving to do so at Pfizer ever since. And one of the main North Stars that we've had since that time was equity, which in our minds is the right to be seen, heard, and cared for. So that continues to drive us. And I think you've seen, we've made the commitment to supply 1 billion doses of our vaccine to the US government for donation in low and lower middle income countries this year, and another 1 billion next year. And our manufacturing colleagues are working round the clock to make that happen. Not just for those countries, for all countries. And so I think, beyond that, we can have vaccines, but that doesn't equal vaccinations. So in addition to making the vaccine available, we also have to, to have the right partnerships enable for distributions to happen within countries. So we continue to partner with the global health community, with organizations, with NGOs, with partners who are actually helping distribution to ensure that the vaccines that are available are distributed equitably throughout the world. And those conversations continue and actually really push us to, again, ensure that we can meet the goals that were set.
That's great. Thank you. Samuel, over to you. Zipline has successfully distributed tens of thousands of COVID-19 vaccines supplied by COVAX throughout Ghana. Can you elaborate on how your team has been able to create these opportunities for vaccination in Ghana? And what key lessons have you learned that others may want to take away as a part of our conversation today?
Yes. So in Ghana, we've partnered with the government of Ghana through the Ministry of Health and the government and the Ghana Health Service to create the world's largest drone delivery network at national scale through a fully integrated system that ensures that there's true last mile delivery being achieved by employing the use of both ground and aerial logistics in a very complementary manner that looks more like a lock and key system. Now, this system optimizes the healthcare supply chain by making it very resilient and making it very robust against some of these issues like pandemics, which we currently are in one. We currently have 4 distribution centers which we operate at an 80-kilometer radius each within rural communities in Ghana. And from these centers, we have distributed more than 155,000 doses of COVID-19 vaccines. And we've also delivered, aside this, 4 million doses of regular immunization vaccines as well. We've been able to successfully do this due to a strong collaboration we have with our key stakeholders within the supply chain space, the expanded program on immunization, who are the main stakeholder in country with respect to vaccine distribution. And because of the general advantages of having aerial logistics implement ground logistics, we've been able to collaborate with EPI in a lot of other ways to make sure this works. The first is that we have dedicated hard to reach areas within the region where ground logistics will not be able to naturally be able to serve. So we collaborate with the expanded program on immunization to make sure that these dedicated hard to reach areas receive their vaccines on demand and they are able to get their COVID-19 vaccines to them directly. By hard to reach areas, we mean islands, we mean mountainous areas that are very difficult to navigate, areas with very bad roads. You even have areas that in a dry season it's a plain land, but in a rainy season you cannot even identify the location. It's completely taken over by water. And some of these areas would have benefited actually from Zipline's drone delivery service. You also have areas that have been flooded due to their terrain, and trucks are not able to go there, and so we collaborate with the state to make sure that those areas that are flooded during the rainy season are able to receive their COVID-19 vaccines as well. We also have areas that are further away from the cities that would have taken a lot of effort to get to. It'll probably take you hours driving with a truck from one point to the other. There's a chance that you even have some of the vaccines going breaking points because of some areas not having very solid road networks, and so we're able to support in that regard as well. You also have facilities that are lacking the requisite cold storage capacity, and so Zipline is able to support in that by working with the expanded program on immunization. And also you have teams that are on the field who at some point will need extra vials to be able to continue with the work that they're doing with respect to vaccination, and they're able to do this by getting it on demand from Zipline as well. Some of the lessons that we've learned have been really great. Technology has evolved, and it's if taken up really strongly, there's a lot of advantages that could really improve the health outcomes of people. Supply chain can really be reimagined to achieve true last mile when 2 or more complementary pieces are put together. And also being open to change also has a lot of gains within the health space, because some of these traditional supply chains have been there for a long time. Adapting to the use of drones is a new thing, and so being open to change is able to bring a lot of gains as well. A lot of cost savings is also in there by using complementary technologies, and also public-private partnership and collaboration has also been very powerful, and that has also helped us be able to achieve this feat.
That's fantastic. Thank you so much for that. Dr. Varghese, I want to get your perspective. We talk about this every single day within Americares as part of the work that we do in terms of medicine security, global supply chain and logistics, and also this idea that it's more than just getting the shots to the communities around the world. It's everything that goes around it. The continued diagnostics and treatment prevention and vaccine confidence, all of those perspectives. So I'd love it if you could share with us, from your point of view, some of the key points that you see and how we can, as a global community, equitably distribute COVID-19 vaccines.
Yeah, Stephanie, I really echo what Julie and Samuel have already shared in terms of the importance of partnership and innovation in terms of equitably being able to distribute COVID vaccines. I think what Julie said about vaccines does not, equate to vaccinations is so spot on. There are so many steps along the way from getting vaccines into different countries to actually getting those shots in arms. So you think about the health workforce and having sufficient staff to administer vaccines, trained staff to administer vaccines, all of the logistics, that Samuel described. Thinking about health literacy and overall kind of vaccine confidence, when these vaccines reach vulnerable communities. And so there are so many different pieces along that full spectrum to really ensure that, the vaccines then, equitably do reach the communities that we serve. And so when I think about partnerships, one example is in India. We have a local hospital partner who has the vaccines but needed support with logistics and operations. And so our team in India was able to partner with the local hospital to be able to bring COVID vaccinations to slum communities in Mumbai. And so those partnerships are really so critical to ensure access to some of the harder to reach communities. I would also say, just in terms of advocacy, when I think about national rollout plans for COVID vaccinations, there are still some groups that are not part of those vaccine rollout plans, like migrants, refugees, displaced individuals. And so continuing to elevate the voice of those communities is also really critical, I think, to achieving equitable vaccine distribution within the countries where we're working.
Right, thank you. Samuel, you started to touch on this, and I think it's a perfect opportunity for us to pivot into a conversation around the global supply chain and the challenges that are there. So, with the rapid spread of COVID-19, obviously triggered the shutdowns of companies and industries around the world. And as a result, supply chains are facing huge challenges. And we're seeing how it's all interconnected and easily disrupted in terms of sometimes the fragility, if you will, within global supply chains and the need to look at new technologies and last mile health delivery. So I'd love to get, Samuel, your perspective on how are you and the Zipline organization thinking about resiliency and equity within supply chain? And I think what you're trying to do through your autonomous aircraft delivery and drone delivery is really getting at some of those opportunities. So Samuel, would love to get your thoughts here.
Thank you. And I think COVID-19 has really quickly proven how well connected we all are. The world is indeed not that big. And when something as important as global supply is affected in one part of the world, it definitely has a ripple effect on a lot of things, including healthcare. As mentioned early on, when healthcare supply chain is really interrupted, the patient is the one that ultimately suffers that unavailability, and the erratic and inconsistent supply and a general sense of medicine insecurity comes up. And we are all connected not only because this world is together, but also because the whole medicine value chain and supply chain is linked together, from the manufacturer's point of view to importers and distributors to the payers, the financiers, the managers of the healthcare supply system, healthcare professionals who are taking care of the patients. And therefore, whenever any of these key members of the supply chain system are affected, it may lead to a disruption of supply, and therefore we need to become resilient globally. And that means that there has to be some kind of robustification of the whole chain in a manner that does not break it. And this can be done by having like more of an integrated system instead of working in silos, right? When it comes to the work that the policymakers have to do, the governments must own their direction of the healthcare supply chains and make sure that certain policies and policy decisions would be able to set the tone, like we have been able to do and are still doing with the government of Ghana, by integrating drone delivery services in our healthcare supply chain. Without strong policies that lead to strategic supply chain roadmaps, supply chain systems won't improve. When it comes to financing, globally, we need to look at using pooled funds from donors, from governments, bringing all this together. For example, in Ghana, we have what we call a basket fund that is used for contraceptives, vaccines, and other categories of essential medicines. And so the donor groups around the world would definitely be key players in here when, with respect to financing, we go all towards a pooled type of system, and that brings more stability. When it comes to the supply chain, the core supply chain itself, the integration of systems that would allow smooth movement of products to the doorstep of the patients is something that would make the system really robust. Using category specific approaches. For example, in Ghana, we have the HIV program, the TB program, the contraceptives program. These separate category specific programs allows us to put more focus on these programs. It allows us to be able to have in place strong performance metrics that would help us track these specific programs for all the way to the end, which helps us be able to ensure that the patients on these programs are able to benefit. And also the introduction of innovative technologies as ours, and integrating it really is going to be of great support. What Zipline has done in Ghana has been one of not throwing in our system and expecting it to work as a parallel system, but making sure that it works as an integrated system with an already existing system, as a means of optimizing the supply chain system and not running as a parallel system. That is something that will definitely bring in a lot of benefits. I think generally around the world as well, COVID has shown us that health system strengthening is something that is really important, and governments around the world definitely need to put a lot more effort around health system strengthening, capacity building, to make sure that with respect to the whole supply chain, every key stakeholder is well supported.
Thank you so much for that. Now, Julie, on top of your role at Pfizer, you also have a background in supply chain management. So I'd love to get your perspective on how you think we can start thinking through resilience and equity in the supply chain.
Thank you, Stephanie. Right, prior to this role, I worked in Pfizer's commercial supply chain organization, and we operate one of the most sophisticated supply chains probably in industry. But what we don't have visibility to is really that last mile supply chain. This is where we don't have a lot of control, and we truly rely on our partners, partners like Zipline, who is a Pfizer partner, for distribution, and Americares, obviously a great partner as far as health system strengthening and healthcare worker training. These are the areas that kind of take over when our supply chain ends. And I think it's really important for us to have a lot of partners, get the insights from the partners, have them meet our internal supply chain colleagues, and really talk about equity holistically, because we don't understand a lot of those challenges in the last mile supply chain that probably lead to there's probably things that we can do in the last mile supply chain that will help our supply chains in general be more equitable. And I truly think it's these partnerships that help make that connection. And that's actually why I love my job, because I love working with these partners, but then also bringing in the supply chain colleagues that we have at Pfizer, so we can look at the supply chain in its entirety.
Great. So, Dr. Varghese, I have a question for you in terms of the different types of factors that make medicine acceptable or unacceptable. The European Medicines Agency defines acceptability as the overall ability and willingness for a patient to use and caregivers to administer medicines as intended. This includes acceptable medicine dosage, appearance, the form, and many other variables. So, given that, how can we make sure that medicines are acceptable and for different communities and different people? And how do we think about making that process more equitable?
Mhm. That's a great question and a very big topic. I would say, just to start, I would share that there's so many factors that make medicines acceptable. There's the individual and their personal experiences. There's contextual factors around culture or family, all of which impact and kind of affect that acceptability factor. I would say really focusing on local contextualization is so important. Listening to the stakeholders, really understanding what are their specific needs and the challenges that they face, and in thinking about kind of medicines being acceptable. I loved what was shared in the first panel session around the community being the number one partner. And really, when I think about health projects, for Americares, we talk a lot about human-centered design. And that concept, I think, really is so applicable to this broader concept around medicine security and medicine acceptability. So you have to really take into account what are those different factors that would make a medicine familiar or desirable or acceptable for broader use. So one way we do that at Americares is we have really robust review processes and discussions with our partners on every single medicine that we send. They have the final say in terms of the specific medication, the dosages, the quantities, because they really have true insight into what their healthcare workers will find acceptable, what their patients and communities that they serve will then find acceptable. And so I think really tying back to that that patient and community and healthcare worker voice, and being driven by those insights instead of what we may think makes a medicine acceptable to the communities where we're working.
That's great. I'm going to toss this one back over to Julie. You all have play such a significant role in the Partnership for Quality Medical Donations, which is known as PQMD. And as we talk about equity and the role of public and private partnerships and NGO partnerships, as you think about equity, and I know that Pfizer has been such a phenomenal partner in the space, why is it so important to donate medicine?
Yeah, thanks for that question. I think in recent years, there's been such a focus in global health on sustainability, which is incredibly, incredibly important, and it should be the focus. But normally when we talk about sustainability, we normally talk about the fact that medicine should be purchased rather than donated. And I think in most scenarios, that is the case. And including at Pfizer, we are always looking at ways to make our medicines affordable and accessible through our commercial channels. But I do think there are spaces for donations. We've seen this in the COVID pandemic. We see this across the board. There are still communities, there are still countries, there are certain populations where a donation is probably the most efficient way to provide access to medicine. There are refugee populations, there are humanitarian crises, there are the poorest of the poor who under any circumstance would not be able to pay anything for a medicine. I'm thinking about the neglected tropical disease initiatives where donations play an incredibly important role in the elimination of these diseases. And then also working with NGOs like Americares, if there are humanitarian crises or natural disasters where there's a very specific gap that needs to be filled quickly, a lot of times that product donation makes the most sense, while a longer term, more sustainable, pathway is established. So we do believe that product donations have a role among a lot of different access strategies. And I think that that will continue, even as we move on through the years.
Well, thanks for that. We have one question from the audience that we will take really quickly. Does the concept of medicine security prioritize certain types of medicine? So why don't, Dr. Varghese, why don't we start that one over to you?
Sure. I think that's a really good question. In my perspective, I would say we've made a lot of progress in terms of medicine access for infectious diseases. Julie mentioned the neglected tropical diseases and how donations have played such a critical role in terms of broadening access. I think, certainly when I think about medicine security, I think about all different types of medicines and all of those different factors that play a role in medicine security. I really think that chronic disease is a critical area where we need to really focus in on medicine security. So, thinking about the global burden of chronic diseases, the number of deaths, the majority of which are happening in low and middle income countries, I think that we have a long way to go and more work to be done around medicine security, specifically in the area of chronic diseases.
That's great. Well, listen, we've covered a range of topics today, from supply chains to vaccine equity, all in the larger macro conversation of medicine security. To close things out, I'd love to ask each one of you, what elements of medicine security do you think are most urgent, and what gives you most hope for change? So, Samuel, let's start with you.
Yeah. So to me, the equity part of for me is pretty urgent. Where I come from, there's still a lot of gaps in service delivery. I'm sure it's the same across the world as well. These are people who may be in certain geographically disadvantaged locations, in islands, in peninsulas, and also below their poverty line. And there's still a lot that could be done. Even though COVID was a hard thing, was a hard and bad thing to happen to the world, it has exposed a lot of the gaps in our healthcare systems. And I am most hopeful that with all the technological advancements and changes happening in the health system, policymakers would also fall in line quickly to set direction to close some of these gaps, even as we continue to fight off COVID.
Oh, thank you so much for that. And then let's go over to you, Julie. What do you think is most urgent, and what gives you hope around medicine security?
Thank you. Yeah, I have to agree with Samuel. I think the pandemic really exposed the gaps in equity around the world. But that does carry into what's most hopeful, is that I think in this virtual world, the speed at which we've been able to partner and the global health community come together quickly to address some of these challenges, especially looking at new technologies, looking at innovations, looking at new partnerships, has been pretty unprecedented. In the past, we used to have to fly to meetings. We used to really only connect with the organizations that, were within our geographical travel distance. But now it's just as easy for me to talk to Samuel as it is for me to talk to Dr. Varghese. So I think that I have truly seen that in this pandemic. The number of new partnerships that have formed is really inspiring. And I think that gives me hope for the future.
Oh, that's fantastic. Over to you, Dr. Varghese. What do you think is most urgent as we look at medicine security, and what's giving you most hope in the work that you're doing every single day here at Americares?
Mm-hmm. I'm going to continue the theme of the COVID pandemic, I would say, in terms of, what is most urgent in my mind and also gives me the most hope, really focusing on the global vaccine distribution is really so critical. And similarly, I think the pandemic has exposed so many challenges that were pre-existing even prior to the pandemic, but has really helped move some important conversations, and when I think about all of the advancements that we've made as a result of the pandemic, just the tremendous work that Pfizer and other, of our pharma partners have made around vaccine and other therapeutic developments, all of the ways that we've leveraged technology for patient care, incorporating telehealth, making it easier for patients, individuals, communities to access medical care. I think that we've really started to lay a foundation for being able to tackle other critical health issues like medicine security in the future.
Great. Thank you so much for that. I want to thank each one of you for taking time today to prioritize this conversation, not only around equitable access to medicine, but health equity in general. We most appreciate it. And we really do appreciate you joining this panel conversation today. I think hopefully for our audience who's attended, there is excitement about the concept of medicine security and the role that all of us have to play in delivering medicine security to every single person around the world. And I'm sure everyone who's attended will be excited to continue to see the work that all of us are doing together.
Today, we will be discussing one of the biggest challenges facing the world, climate change, and how it is disproportionately affecting the health of people in poverty and marginalized communities worldwide. The scope of the damage that can be inflicted by a changing climate makes it one of the most dangerous yet preventable risks to human health. And many of those whose health is most affected by climate change today and who are at most risk for the future are in communities already at risk for poor health because of poverty, neglect, and discrimination. Those with the least resources often suffer most in the aftermath of major hurricanes, drought, wildfires, and other climate-related emergencies. One recent study found, on average, more than a third of heat-related deaths in many parts of the world can be attributed to climate change. In some parts of Central and South America, the region I oversee programming in, it can be as high as 70%. Today, we will explore the impact of our changing climate on health and discuss solutions for health providers already seeing the effect that extreme heat, more frequent and intense storms, and increased flooding is having on their health and the health of their communities. We're going to have time for questions at the end, and you can add your questions in the Q&A box at any time. But before we get started, we have a very special message from the White House National Climate Advisor, Ms. Gina McCarthy, who recorded this short video before heading to the United Nations Climate Summit in Scotland.
Hello, Americares. I'm Gina McCarthy, President Biden's National Climate Advisor, and it's great to be back with you, even just virtually, but I'd rather be there in person, just to talk about how we are all such kindred spirits. You know, in the end, we care about our families, we care about our communities, we care about our kids' future. When you come down to it, health is fundamental to everything we care about and everyone we love. You know, I'm working on the issue of climate change because I know it's not about the planet. It's about its people. It's about you and I and how we live together and whether we can deliver a healthy, yes, a healthy future for our children. Just think about how many people have been impacted just in the US by the droughts and the wildfires and the heat stress and the terribly intense storms that we're all facing and the flooding. You know, we are at risk if we don't act together, but be hopeful because we are acting together. We are making huge progress and we are going to go to Glasgow this next week with our heads held high because the United States is back. We're back because of you and all the work that Americare does and all of us who care about leaving our kids a future that we're going to be proud of. So keep holding your head up high, keep being hopeful, keep pushing. That's what you've always done, and it's been a magnificent success so far. Take care and enjoy the day.
Wow, with such enthusiasm and an inspiring message, I think we're ready to kick this off. So let's meet our panel. Our first panelist is Dr. Oren Bernstein, Interim Director of the Center for Climate, Health, and Global Environment at Harvard T.H. Chan School of Public Health. The center, also known as Harvard Sea Change, increases public awareness of the health impacts of climate change and uses science to make it personal, actionable, and urgent. Dr. Bernstein, who is a pediatrician as well as an assistant professor of pediatrics at Harvard Medical School, studies the health impacts of the climate crisis on children's health and advances solutions to improve the health and well-being of children around the world. Welcome to the panel, Ari.
Great to be here.
Great. Kristen Stevens is Americares Director of Preparedness and Disaster Risk Reduction. She directs initiatives that strengthen health systems in vulnerable communities to help save lives. Her work includes implementing programs that provide safety net health centers with the tools to better prepare for future emergencies and continue to operate despite power outages, facility damage, and other obstacles. A certified emergency manager, Stevens has more than a decade of experience in health sector emergency management, including serving as Director of Emergency Management for NYU's Langone Medical Center in New York City. Welcome, Kristen. Dr. Alexis Hodges is a family nurse practitioner at the Community Care Clinic of Dare in North Carolina, which provides medical care, medication assistance, and wellness education to low-income patients without health insurance. The clinic serves 670 residents on the front lines of climate change in a community that frequently floods due to rising sea levels and severe storms. She has a doctorate in nursing and has over 30 years of experience in the medical field as a volunteer, a provider in private practice, and as a clinical associate professor of nursing for East Carolina University. Welcome, Alex.
Thank
you. Yeah, let's get started. And I think I'll kick this question to all three of you. I want to hear from all three of you on, understanding that we have a warming planet, and we know this can lead to drought, extreme heat, more frequent and intense storms, even more mosquito-borne diseases. All of these can have adverse consequences to health. So in your line of work, what do you see as the biggest health risk due to climate change? Ari, why don't you kick us off?
Oh, thanks, Brenda. So climate change matters to everyone's health, and especially the health of the most vulnerable. It really spares no part of our body. And so the biggest risk to our health when it comes to climate change is if we don't meet the targets set out in the Paris Agreement. But on the flip side, in this near term, we can alleviate so much harm through acting to reduce emissions from burning fossil fuels. It's important to recognize that fossil fuels drive an astounding amount of disease burdens, both here in the United States and around the world. It's estimated that 1 in 5 deaths globally are from air pollution that's created from burning coal, gas, and oil. And in the United States, that's about 300,000 people die from fossil fuel air pollution. And you put that in the context of what we've seen from COVID-19, you realize we're losing so many lives every year, which we can prevent as we take actions to address climate change.
Thank you for that answer. And sorry, I actually got cut off because of a power outage. So, Kristen.
Yeah, thanks so much. This is definitely a big question, and there's a lot to unpack here. I think the thing that I think about the most is when we think about the health of patients, I'm also thinking about where they're getting their care, and I'm thinking about the health of the health centers themselves. So what we're seeing with climate change is we're seeing increased disasters impacting local health centers, which is Americares' primary constituency that we work with. We are seeing health centers sustaining physical damage. We are seeing healthcare providers working under tremendous stress due to COVID and following other kinds of disasters as well. We are seeing people moving into communities and greatly increasing the patient population. We're seeing people moving out of communities, decreasing the providers available to serve people in those communities. And so I'm thinking about it in terms of the overall resilience of the health centers themselves, the resilience of the providers in those health centers, and the ability to provide long-term sustained care.
Alex.
Agree with all of the above. Of course, I think of hurricanes a lot when I think of climate change. We've had increase in storms. It's coast of North Carolina is not unique to that. We've seen that on the Gulf Coast. We've seen it on the West Coast, et cetera, in storms. And so it's kind of a threefold measure when you think of storm impacts and that climate change. You have the hurricane evacuations, which is the first part, which for my area is very unique. There's no public transportation. So how do these patients get to safety? How do these families get to safety? The next part of that figure is we're a large fishing community. So our fishermen are moving their vessels, their boats, to safer harbors, while their families are left behind to get prepared for the storm. We're also a tourist area. So the people that are working to take care of the tourists that are here until there's a mandatory evacuation are unable to prepare for the storm. So they're unable to make sure they have medicines, they make sure they have groceries, make sure they have supplies. The health impact that hits next is, of course, the actual storm itself. What happens afterwards? There's flooding. Oftentimes, there's loss of power, loss of air conditioning with that power. So you've got that heat impact, but then you've also got the disease impact with the mosquitoes, the snakes. We also have, we don't have, our septic systems are private for each home. So when you're walking through flood water, you're walking through septic water. And so there's a major contamination and health risk there, which then leads to the next part, my third phase of the flooding and consequences of storms is what happens to homes. Homes that are flooded have mold, mildew, and those health consequences are tremendous and impact largely a respiratory illnesses such as asthma or chronic obstructive pulmonary disease.
And you've certainly, among all three of you, have really highlighted all the challenges that at the various levels that we're experiencing as healthcare providers and working in this environment. But Ari, your team at Harvard is working with Americares, disaster preparedness experts such as Christine, on a groundbreaking project that will prepare healthcare providers in communities experiencing climate change to meet the health needs of those most at risk. Can you tell us a little bit about this project and why is this different from other preparedness projects? Why this hasn't been done before?
Yeah, thanks for that, Brenda. So our partnership with Americares is focused on addressing what I think is one of the biggest unmet needs in terms of preparedness for climate, and that is doing preparedness in the context of frontline health clinics. When you look at the work that's been done on preparedness for climate change and health, it's almost entirely been the purview of hospitals in big cities. And we know that when disasters strike, the focus of attention shifts very quickly to the distal parts of our healthcare system, the parts that are closest to where people live, whether that's the wildfires in California, the hurricanes on the Gulf Coast, and the heat waves and floods elsewhere. We see that as communities work through these events, their needs are most often met through the clinics that serve them. And yet we have very little guidance and very little empowerment of those clinics to do more to address those needs. So that's where we're starting from. And Americares has this just fantastic network of clinics that they have worked with through disasters. And we're seeing opportunities already to leverage the knowledge that is in the staff of these clinics about the people they serve to start to find ways to prevent harms that are foreseeable, just like the ones Alex was talking about when these disasters strike. So what does a patient-centered, heat warning system look like, so that we're not dealing with people showing up in emergency departments and in ICUs, but we're setting up plans that reflect that individual's medical history and their access to resources like cooling centers in ways that make sense and are doable for that individual. So we're really excited about it. We think it's enormously important given the risks we're facing. And I might add that one of the potentially most powerful parts of this is that we know that the climate issue in the United States is politicized. People see it as a partisan issue. And in order to make progress, the progress that science shows we must make to protect our health, and especially to protect health equity, we have to depoliticize it. We have to make it personal. We have to make the issue actionable. And talking about health and health equity is a key part of that. We have lots of research showing that talking about climate as a health issue takes it from this realm of politics and moves it into the realm of action. And so by working with the staff at these clinics, we also enlist a group of enormously important and powerful voices for the communities they serve to speak about how climate change makes it harder to do their jobs well, to deliver the high quality care they want to deliver, and critically, as I alluded to before, that climate actions are health actions and they promote health equity. So we see really wonderful opportunities to both protect vulnerable communities that these clinics serve and to hopefully get some more voices engaged on talking about climate as a really important health issue.
You know, Ari, I couldn't agree with you more. And thinking back to Hurricane Maria, certainly what you highlight, which is how important those community health centers are in providing that first assistance and making sure that the community has all the tools to manage what's to come and what they're facing. We certainly saw that during that time here. And, you know, trying to loop that in to the work that Kristen is doing. Kristen, you know, with so many climate health or climate related health threats and challenges, how do you help these healthcare providers and these health centers prioritize?
So that's a great question. So what we do, we take a risk-based approach. So we work with the health centers to find out what are the types of hazards that they are most vulnerable to in their area. We look at it in terms of their overall preparedness to address those hazards. And then we also look at the potential impact of it. So we want to and combine that with the probability of something occurring. So we look at all four of those pieces together and help health centers rank and figure out what are the most pressing concerns. And there might be something that might be less of a probability, but have a greater risk to them if it does happen. Or there might be hazards that are frequent and people are prepared for. In the Gulf states, they experience a lot of hurricanes, for example. But we also help with that, with the prioritization. We make sure that people aren't focusing so much on the hazards that they know that they're not paying attention to other hazards outside that specific sphere. So it's an ongoing process of identifying hazards, assessing risk, reassessing risk, and making sure that providers and health centers are keeping their eye on the ball and not focused so much on what's right in front of them that they don't see what's coming up behind them.
You know, that's fascinating, Kristen, that we don't take a cookie cutter approach, right? From what I'm hearing from you, we tailor. We work hand in hand with those centers to make sure, and with those providers to make sure that they have the right information to, as you say, prioritize and make the best decisions for their facilities and the communities that they serve. And thinking of that, Alex, yeah. No, and along those same lines, Alex, you are in the Outer Banks and you have very particular situations, very particular experiences, especially with flooding, as you mentioned. Can you talk to us about how climate change is affecting your patients on a more personal level?
Absolutely. You know, again, climate change impacts with the storms, with the flooding. If you think of patients that are in housing that is limited, number one, on the Outer Banks, so to give some perspective to that, Dare County actually encompasses a little over 80 miles of land. Hatteras Island is about 65 miles of that, and that is one road in and one road out. So if transportation is already an issue and then you have road issues, patients cannot seek care at their providers. The Community Care Clinic of Dare actually has two facilities, one where I live on Hatteras Island, and then one, as I was mentioning, the 70 plus miles north of me in Nag's Head. And so patients, we are only open one day a month on Hatteras Island. Patients on Hatteras Island have to figure out how to get to Nag's Head. And so if they already have health disparities because of their income, housing, and then is impacted based on flooding. So Dare County is, again, it's a tourist area. So housing is very, very limited. I serve on the Dare County Board of Health and Human Services, and one of the topics at our last meeting was affordable housing for our first responders. So think about that. Our first responders have jobs. They have insurance. They have means for transportation, yet they cannot find housing. So our patients that meet our underserved areas here that have our health disparities, have our income disparities, they don't have access to care, so they don't have access to housing. It's a huge topic.
Yeah, no, certainly, and you know, it makes you wonder, how do we make sure that we help these providers, these first responders, have all the tools, all the needs when we talk about their well-being. But let's shift things a little bit. I also want to pick on Ari a little bit because I try to follow all the challenges that climate change can also bring to food and water resources, the food and water security, and that's sometimes a little bit overlooked. So, Ari, how can we help patients address food and water insecurities issues related to climate, this changing climate?
Yeah, it's a really important question, Brenda. It's astounding, as important as food and water are to human survival, how easily they can be overlooked. And one of the aspects of the work that we're doing with Americares, and that I should definitely mention, was supported and is supported by Biogen, who really saw the importance of this work to focus on climate resilience through frontline health clinics, is for the health centers to really understand these risks within the communities they serve, and to work with the communities to understand where resilience may come. And a really good example of this comes from Texas. Texas, subject to hurricanes, and hurricanes can interrupt all kinds of basic services, including water, whether it's because water filtration systems fail or pipes burst or other effects. And one approach to dealing with that problem is to put, community filtered water that's in buildings that are resilient to hurricane effects. But of course, during hurricanes, people may not be able to get to those places. And so in one of the clinics in Texas, they've started a essentially community-based water filtration program where water filtration supplies, whether that's reverse osmosis or water purification tablets, are positioned in strategic points throughout neighborhoods in their communities that the people they serve know are there, so that if they have a boil water order or the water's not coming out of the spigot, they can access those resources in ways that are much more available to them than would otherwise be. So the short on food and water security is, assess now, and I think clinics in particular have a really good sense of these risks for their communities, conserve now and prepare for later. And the prepare for later piece critically has to be informed by what is doable within the community that you're operating in.
No, thank you for that answer. I don't know if anybody else wants to chime in on that. Kristen, I see your camera on.
Back, yeah. Thank you.
Okay. Well, I live in Puerto Rico, and I know all too well what it's like to experience back-to-back disasters that put challenges on all of those resources. We've had epidemics of mosquito-borne diseases, major hurricanes, earthquakes, massive power outages, and drought, which triggered some water rationing. And that's just alone in the past 5 to 6 years. So all these compounded traumatic events can have a detrimental effect on the mental health and well-being of people living in these affected communities, and certainly the healthcare workers. So Kristen, how does Americares help healthcare workers in disaster-prone communities prepare for these emergencies?
It's such an important question. At Americares, we have robust mental health programming in general. Those of you who've been with us this afternoon heard about some of that. But one of the most exciting things that we've been doing in the last year is bringing together our mental health and preparedness work into an integrated program. Because we know that on the preparedness side, it's not enough to have emergency plans in place and have a backup generator and all of that. If the healthcare workers aren't in a good position personally to be able to respond. So we are living through incredibly stressful times. And for many of the healthcare workers that we work with, day-to-day work is stressful, right? They work with people who have tremendous needs, often resource-poor environments. It can be very stressful work. Now compound that with a disaster. So what we try to do is figure out, how do we marry those things together? So you can have the best plan in the world, but if you're not personally equipped to carry it out, right? And if your staff doesn't have the wherewithal to continue to care for themselves and care for each other, they're not going to be able to care for their patients. So it's a really exciting development that we've piloted this past year in California, and we are looking forward to rolling that out on a more wider basis.
That's fascinating. Thanks for sharing that. And Alex, speaking of mental health, earlier you kind of touched on some added issues about stress disasters and how they, that places additional stress on your patients. Can you talk about how you address the mental health impacts for your patients?
Absolutely. And kind of to give you a little bit more background about the patients, a prime example can be during a hurricane, post-hurricane, I should say, on the island, you will have patients that, again, cannot access care. So we providers will go directly to the house. We've called the pharmacies out to get prescriptions, et cetera. And one of the biggest issues that we really try diligently at the community care clinic is to make sure our patients are prepared as much as possible to have the prescriptions and the medications that they need and know where the support systems are prior to an event. So let's talk about an event. It's kind of like post-traumatic stress disorder. People who live in hurricane-prone areas probably can agree with me. Probably 98% of the population goes into planning mode as soon as we start hurricane season. We're checking the weather app. We're checking to see when a storm's coming. We're preparing. We're monitoring the weather. We're stockpiling. But again, what happens when you don't have access to care? Because you can't find a physician, you can't find a provider. Again, going back to the area, and I hate to blame COVID, but COVID has caused people to relocate to secondary homes. And so you've had an influx of the population. So Dare County has a population year round about 37,000. And in the summertime, we swell to over 300,000. There's not enough healthcare providers for that on a normal day. And then you add some of those families coming back in and living. So there's not enough providers to go around. You may be traveling the 70 miles to seek access to care. And mental health is even more thin lined as far as the number of providers. We are extremely deficient in that area, I think nationwide. I think if you spoke to any primary care provider, they would say they are routinely managing diseases that we normally would have had the psychiatrist see. We're not just talking depression, we're talking depression, anxiety, suicidal ideations, etc. So mental health is huge, and we on the forefront are meeting that challenge. We meet the challenge in our clinic with utilization of our resources. And again, you may be limited, but you kind of do with what you can. Just a couple weeks ago, I had a patient who's living in a literally one room with a bathroom, no kitchen, with her 4 children. So you have major health disparities for food, for water, for medications. Who's helping her and her mental health, but who's helping care for the children that are age 3 to 13? And she's by herself and she's having to go work the 12-hour shifts. So we really are trying to be very proactive. We gave that patient numerous resources, even went the extra mile of contacting legal aid for her for her citizenship, etc. So I think it's important that we encompass the entire patient. It's one of the things I teach my students. We always want to drive home that you're doing the complete history and physical. Well, oftentimes mental illness or even I shouldn't say mental illness, just the psychiatric wellness screening is what I like to call it. Everyone needs that psychiatric wellness screening. Are you depressed? What situation, what can we do to help? And so on the forefront, we need to be proactive rather than reactive.
No, certainly, Alex, and it's important to, as you say, look at the patient holistically, right? It's not just absence of disease; it's the entire patient, their mental well-being, and making sure that they have the resources needed in order to continue forth. And again, talking about adequate resources, and earlier in the week, Ari, when we were getting together to discuss what topics we might be interested in touching upon for this panel, you mentioned the precisely not having adequate resources in Massachusetts, where you're at, for the enormous influx of people displaced from Puerto Rico right after Hurricane Maria. So again, what can we do, taking that into consideration, and also what Alex just shared with us? What else can we do to make sure that we don't task our already stretched thin resources?
Well, Brenda, I think that's a great case and point for one of the rationales of our work with Americares, which is to empower the voices of folks working on the front lines so that their voices are heard for the communities they serve in policymaking decisions. I think we absolutely need to do more to make sure that we're prepared for people being displaced, whether that's within states or even within towns, or as the case of Maria and Puerto Rico makes so clear, from an island into the mainland of the United States. So I think it really is an issue that deserves more attention. I think our work with Americares is a great example of how we can elevate voices that aren't heard enough in how we think about preparedness around climate. And I'm hopeful that it's a part of a broader wave that we're seeing that will make us much better prepared for what's already happening and what we can see coming down the road.
Yeah. And, again, trying to tie all connect all the dots. Kristen, how do we then take that that idea and choose from Americare's perspective, right? How do we go ahead and decide with which clinics we think we need to work? What helps us as an organization prioritize?
Yeah, that's a great question. It's we look at a number of different things. So one of the things that we know is that no one is immune from the impacts of climate change. So we're not just targeting specific health centers up front, but we are looking with areas where we have strong partnerships. One of the really exciting things about this program is that it brings together the academics of Harvard with the operational experience of Americares, with the health centers who are doing the real work on the ground. And so it's a real opportunity for us to basically translate the work that is coming out of Harvard, work with the health centers to turn it into something that works for them, right? So we're building tools that are customizable to the local context, that we can adapt as needed. And so when we're looking for partners, we're looking for people who are excited about this, and we're looking for people who recognize the need. We're starting off with 9 pilot health centers. They've all been very interested and engaged, and then we're looking to roll out from there. This is something that we know that affects everybody. Pre-COVID times, we would do what we called our preparedness boot camps. And we always concluded them with a tabletop exercise where health centers would work through a simulation, and they would take everything they learned in the boot camp and try to apply it in a real scenario. And some of the pushback that we had frequently gotten is that the health centers would say, well, we don't have disasters here. Outside of places that were in specific hurricane zones, they would say, we're not really impacted by disasters here. But they thought that this was sort of a good thing to do, so they would do the program. So our tabletop exercise was always a pandemic, because we would always say, we can all be impacted by a pandemic. And so, of course, it's terrible that we were right about that. But I think it also gives some credence to the notion that, we're thinking bigger and broader than we're trying to look much further down the road, right? So many of the health centers, we've talked about the resource restrictions and challenges and so forth. So many of the health centers we work with are trying to solve immediate problems. And what we're able to do in our partnership with Harvard is look further down the road and say, this is what's coming, and let's get you ready for it now. You're experiencing now, this is what's coming further down the road. We are starting with health centers that have expressed an interest in it, and we will be recruiting widely for it. But our goal is to get this out to as many health centers as we can, because it is going to impact all of us now and well into the future.
Thank you for that. And Alex, bringing it home, right, for the healthcare centers, what are the things that you as a provider at one of these very critical community-centered facilities, what would you like to see from us?
Again, I think we're doing it. We're being proactive instead of reactive. And again, being policy change makers. I preach that to my students, that we can be the change agent. We try to do something positive for each patient and figure out what it is those patients need. And again, like Kristen said, let's be proactive. No one would ever thought we would be in the pandemic that we're in, but yes, disasters happen. They happen whether you think of them as a true disaster or not. A house fire can be a disaster, and it is. Living in Eastern North Carolina too, we have a lot of migrant farmers, migrant fishermen. So bringing in that health disparities, bringing in equity for healthcare. For me, my translator on my clinic days is I can't function without her. And that's huge that we have that access to care for those patients. We're being proactive. We're making sure we're getting the vaccines out there. We are doing the medication assistance programs. And I think kind of wrapping it up, bringing it back home to Dare County. What you may not be aware of is some new regulations with flood zones and FEMA. And the regulations that are in our legislature right now will prohibit the average person from ever building a home or owning a home in Dare County. And to me, that is extremely sad. That my patients that I'm seeing, they have no hope for owning a home because they're not going to be able to afford flood insurance. And so again, being that change agent and bringing the whole patient into the picture, every aspect.
No, certainly. So, a lot of things that we have discussed here today, important topics that, and you've helped us tied in all the little pieces about adequate resourcing, policy making decisions, holistic view of the patient, integrated programming, um, stepping aside from cookie cutter approach and actually listening to individuals, listening to the centers. What is it that they need? What is it that they would like to see? And that the immediate that these are things that are not happening in some exotic places. This is not, we're not talking about Vanuatu or anything like that. We're talking about right here and now in our own backyards. We're seeing these effects. So before we leave, any parting thoughts from from all of you? Ari, let's start with you.
I'm really encouraged by the conversation here, and I hope those who are watching also have felt some sense of a path forward in what can otherwise seem a really difficult set of circumstances. But it's really a testament to Americares' leadership and the work they've done to really think further upstream and really focus on the unique risks that climate poses to the very mission of the organization, as not to mention all the folks in the communities that are served in the clinics on the front lines. And so I'm very excited about this work. I hope we can really advance what I think are some worthy goals for protecting the health of vulnerable people in the United States.
Thank you. Alex?
I'll just echo Ari. Pleasure to be here and feel revitalized that we can be the change agent. We can make healthcare equitable and make it that there are no disparities one day for our children's future.
Well said. And Kristen?
These are challenging times and these are challenging threats that we face, but I feel hopeful. And for me, one of the things I feel most hopeful about, and I think one of our greatest chances of success, is the kinds of partnerships that we're building here. Different organizations, different people have different missions and bring different skill sets to the table. And I think that our partnership on this is one great example of it. We have shown there have certainly been some challenges globally in the pandemic, but we've also seen so much of what positive things can happen when different organizations and people pull together to try and find a common solution. So that's what I'm looking for and calling for. And for people who are listening, find out who you can partner with. Where are the force multipliers, right? How can you bring different organizations together and come out with something that is stronger than either of them alone? So we are looking to partner together, and Bob will join us.
Thank you. And what a way to bring it home, Kristen. Certainly this call to action, partner, figure out who you can partner with. If we fit the bill, partner with us. As you can see, we have great partnerships going on with Sea Change, Harvest Sea Change, and our work has impact at the community level. So I thank everyone for being here today with us. I thank this amazing panel that has made my job easier at moderating and navigating all these questions. Again, thanks for joining us. And Americares, like we like to say, health is on the way.
Each one of us has a role to play in driving transformational change to a future of true health equity. We hope you found today's summit insightful and thought-provoking. We would like to thank each one of you who were able to join us today and our speakers for taking the time to share their expertise and knowledge with all of us. At Americares, we are so very fortunate to have a constellation of supporters from individuals to corporations, foundations, and public funding partners, all of you who generously invest in our shared vision of a world in which all people have pathways to health and opportunity. Thank you. We look forward to remaining connected with you as we continue to advance Americare's impact in driving health equity through our core programs of medicine security, emergency programs, and health services across the globe. Finally, we are excited to announce our 2022 Americares Partner Summit. Please mark your calendar for Wednesday, May 4th, 2022. We plan to host a hybrid event in New York City and streaming online. Visit americares.org/partner summit 2022. Again, that's americares.org/summit 2022, where you can pre-register. Thank you again for joining the Americares Health Equity Summit. Have a good evening.